I'd like to, first of all, welcome everybody to the Language Equity Summit. We're really excited to be here today. Happy that we can celebrate in this Hispanic Heritage Month. My name is David Parajon. I'm an internal medicine assistant professor here at the University of New Mexico, and we have a great number of speakers here for you today. So far, our celebration has been going really well, and we have even more great speakers for you today. So today we're going to explore the issue of language equity and focus on the barriers that affect access to health for those who only speak Spanish. We also want to look at ways that health providers can overcome these disparities in health that are experienced by many in our Spanish-speaking communities. So between 9 a.m. and 2 p.m., we have a lot of action going on. I hope that you can stay for the whole session. So we hope that you can also enjoy the wealth of knowledge, the experience of our speakers who are going to be connected via Zoom from around the country, and they're going to share their lessons learned with the hopes that you too can not only be aware of the great needs in our communities, but also see new ways to help create solutions, to break down the barriers wherever you are, and grow the hope that we can all live in a world where there's diversity, equity, and inclusion, and especially health for all, especially the most vulnerable people. So as we celebrate this month, all of the hard work of those who have gone before us, those who sacrificed so much for us, so that we too can pass on this hope to the next generation. Thank you. Thank you to all of you for being here. Thank you for listening, and we're looking forward to your questions and participation too. So let's move on to our speakers. I'm going to introduce three of them, and then we'll sequentially go through. And the first speaker is Dr. John Paul Sanchez, and he's the Interim Executive Diversity Officer in the School of Medicine and a Vice Chair of Diversity, Equity, and Inclusion. Dr. Sanchez has worked extensively to promote diversity and inclusion in the medical and academic workforces. He's a co-founder and president of Building the Next Generation of Academic Physician. Since 2009, the Building the Next Generation of Academic Physician has become nationally recognized for developing the concept of pre-faculty development and has collaborated with over 60 academic health centers to educate trainees, faculty, and senior administrators on how to develop upstream pipeline of diverse medical trainees to become future faculty and senior academic leaders. Dr. Sanchez is also on the editorial board of the Journal of Academic Medicine and is associate editor for MedEd Portal. He's also executive director of the Latino Medical Student Association, which is the largest Latino medical student association in the country, with 140 plus chapters at allopathic and osteopathic medical schools across the country. Since joining the Health Sciences Center at the University of New Mexico, he has been selected for numerous leadership positions, including as Executive Associate Vice Chancellor for Diversity, Equity, and Inclusion, whereby he supports 10 HSE entities in planning, organizing, and aligning the diversity, equity, and inclusion activities. He's also published 52 peer-reviewed publications and 6 book chapters, and served as editor for Succeeding in Academic Medicine, a roadmap for diverse medical students and residents. He received his medical degree from the Albert Einstein College of Medicine and completed a master's of public health from the Yale School of Public Health. He is of Puerto Rican ancestry, gay identified, and was raised in the Bronx, New York. The second speaker will be Dr. Valerie Romero Legat. She's Vice Chancellor of Diversity, Equity, and Inclusion Executive Officer at UNM. And she is a first-generation college student, a native New Mexican Hispana with strong roots in her cultural heritage. And she received her Bachelor of Arts degree from Harvard University and her medical degree from the University of New Mexico School of Medicine. Dr. Legat serves as Vice President and Executive for Diversity, Equity, and Inclusion Officer for the UNM Health Sciences Center. She's also a professor in the Department of Family and Community Medicine and as the UNM HSC Endowed Professorship in Equity for Health. She also serves as Executive Director of the Combined BA-MD program, a unique program that promotes the recruitment and retention of a diverse group of New Mexico high school seniors interested in practicing medicine in New Mexico's areas of greatest need. She's been a primary care provider on the forefront of treating populations burdened by socioeconomic, racial, and ethnic disparities. And she has extensive experience teaching cultural competence, developing educational pipeline programs for underrepresented youth, building a diverse health workforce, and providing mentorship and career development opportunities and guidance for diverse faculty, residents, students, and staff locally and across the nation. Dr. Romero Leggett is a role model for young female learners and professional women in the health sciences and has profoundly influential career advocating for women of color. She values time with her family and enjoys the peace and beauty of New Mexico's mountains. The third speaker we will have in the next half hour is Fabian Armigo. He's Executive Director of Diversity, Equity, and Inclusion at UNM. This role includes responsibility over the hospital's Interpreter Languages Services Department, the Native American Health Services, as well as the brand new Office of Community Engagement. Fabian, who's a native of New Mexico, worked as a trilingual, that is Portuguese, Spanish, and English, professional medical interpreter and translator, as well as a licensed interpreter for UNMH. Before beginning his career in healthcare, Fabian worked for the Spanish Ministry of Education as a primary school teacher in Galicia, Spain, where he taught science. He's also studied at the University of Palermo in Buenos Aires, Argentina, and the University of Sao Paulo in Sao Paulo, Brazil. Although Fabian has traveled, studied, and worked abroad, his passion lies in addressing the needs of his community and the home state of New Mexico. He's served in the Albuquerque community in his volunteer roles as a reading tutor to unsheltered women and children at the Barrett House and as a medical apprentice at Casa de Salud in the South Valley, where he worked in harm reduction efforts. Continuing his studies locally, Fabian is currently enrolled in the Masters of Health Administration at the University of New Mexico's Public Health Administration. Without any further ado, I would like to thank all of you who are here today and welcome Dr. John Paul Sanchez to join us for his important part in this session.
Thank you, Dr. Barajon. I just want to say good morning and welcome everyone. It's truly an impressive morning. We have over 20 people on a Zoom call, and we have another 10 to 15 people here with us at the HSC building. What we don't have is good connectivity between Zoom and the programs that we're using. But I want to thank everyone for joining us this Saturday morning. As many of you know, this is part of an ongoing effort to see what we can do to promote language equity within our HSC system at the University of New Mexico. Specifically, how can we better prepare providers to serve not only as English-speaking providers, but also as bilingual providers, whether it's around Spanish, and that's how we came to have this program as a part of Hispanic Heritage Month, and other languages that are common within the state of New Mexico, Dene, Navajo, so forth. Historically, there's been a great emphasis on using language lines, which definitely serves an important purpose to facilitating quality communication with patients. But I think personally, as someone who is of Puerto Rican ancestry and didn't have the opportunity to receive a bilingual education, that in many ways we've missed the mark in ensuring that we can cultivate our own assets around language. So today we have an incredible set of speakers who are going to help us think about what are some of the systems issues, what are some of the systems barriers that have prevented us as an institution and institutions across this country in affording bilingual medical education, not only medical education, but bilingual nursing education, pharmacy education, and population health education. I am happy to share that one of the barriers that we've had to deal with is not having the FTE or the funds to hire such talent to train us all. So as we expand the Office of Diversity, Equity, and Inclusion within the School of Medicine, We will have a director, a posting. So if anyone is interested, I'm going to need your help. So a posting for a director in the Office of DEI is going to be listed in the next couple of weeks. And this director will be specifically responsible for designing, implementing, and evaluating a bilingual medical education component for the School of Medicine. On top of that, another system issue that we're going to be dealing with is encouraging each of the chairs of the academic departments to assign one faculty member, at least one faculty member, with protected FTE. Now, protected doesn't mean new money. What that does mean is identifying a faculty member whose FTE can be reassigned potentially. But I think that will be a pivotal step in addressing a major system issue, which is bringing together a cohort of people with FTE to design, implement, and evaluate medical education content. So I want to thank everyone again for joining us today. And with that, I believe we're going to hand it over to Dr. Romero. Is it Fabian or Valerie is next? Handing it over to Dr. Romero Leggett. Thank you.
Good morning, buenos dias, and bienvenidos. It's such an honor to be here with all of you today, and I really want to express my gratitude to Dr. Barajon and soon to be Doctora Eliana Garcia, Dr. Belmonte, the Latino Medical Student Association, really the entire Language Summit team, you know, Dr. Sanchez and Dr. Jennifer Gomez Chavez as part of our leadership for Hispanic Heritage Month. And so very special that this inaugural summit, right, is occurring during and part of the celebration for Hispanic Heritage Month. So thank you all. And, you know, as we all know, and that's why we're here, this is just such a vital topic for our entire HSC community, and the communities here in New Mexico. And I really appreciate the opportunity to just give a little bit of a historical background here. And you'll be hearing a little bit more too in the panel, the concurrent session about opportunities to develop competency and certification to serve Spanish-speaking patients. But we all know the why. We live the why each and every day. And there has, you know, I'll say that in my entire tenure here at the Health Sciences Center, there's been this deep desire always from our learners, our staff, our faculty, and our patients for Spanish language, medical Spanish, and other language equity. And also valuing people who are bilingual and bring this linguistic beauty to the work that they do. So I'm gonna have, I believe, Fabian will pull up a slide here that gives you a little bit of the history. And thank you to Dr. Plaza for helping put this together. She has the better memory than I do. So this gives you both a timeline that you can see here, you know, from about 2005 to current, but both on main campus and the North Campus here. And I think what's been really important over the years is just, again, to understand, like, just these incredibly committed people over time across this institution who have, you know, created courses and meetings and electives and done research projects, and just, again, this incredible push for language equity here. And in this case, Spanish language and medical Spanish training. So as you can see on the main campus side, on the left-hand side of this slide, you know, there was a U.S. Department of Education grant that kicked things off in the spring of 2007. And then I will say too, in a lot of this work on the left-hand side, you know, Dr. Veronica Plaza has just been a champion and a leader in so many of these opportunities. But what you'll see again is a lot of grants. And then I want to draw your attention to the College of Arts and Sciences allocation of funds, because back in, I believe, 2010, and you'll see it on the right-hand side, actually called the Leadership Collaborative Meeting, this was the time, all the time that I've been here, 20 plus years, that I felt the most hope that actually something would happen with sustainability, because we brought together, I think it was probably about 20 or 30 people from across main campus, Health Sciences Center, the community, who were very much in support of this and really wanted to see if we could figure out a way to create some funding and some sustainability. So out of this collaborative meeting, the College of Arts and Sciences did a national search for a lecturer position, and Dr. Plaza applied for that position and had that and had the position, and has been busy in all of this the rest of her tenure here. So that was a huge plus out of this collaborative meeting. But unfortunately, you know, there were so many moving pieces, and the momentum sort of died a little bit, and we were back to people doing important work, as you can see here, right, in language assessment for our students, in certain electives like the Spanish Practical Immersion experience, our emergency department medical Spanish program by Linda Holtz Villamar. And so just, again, an array of incredible opportunities and trainings, but we still have yet to get to a sustainability, a more sustained programming for our institution, but also, again, the language proficiency testing, right? And what you'll hear next, you know, from Fabian is our interpreter languages services, which is critical. But, you know, Dr. Felicia Rojan Minares and Zoe Schutzman have been incredible, and Fabian Armigo as well, in putting together a proposal for Spanish proficiency, language proficiency testing for the Health Sciences Center. And so these kind of efforts are critical to us. And I'm very hopeful. I'm so appreciative to the School of Medicine and Dr. Sanchez now, and having a person who will help us coordinate and put this all together and evaluate this, because that's what's been needed, like somebody to really be this huge project or coordinator for us. So I think that, and then again, this deep desire and dedication from so many people across this institution and across our communities who really care so deeply and need this, right? Like, this is part of what we need to provide for equitable care here in New Mexico. So again, I am just very excited about today's programming and the momentum here, and just grateful for this summit, because this day really provides us all an incredible opportunity for all of these amazing colleagues and all of you here that have come together, committed about improving language equity for this state and for others right beyond. But again, I really believe that the conversations today will form the basis for action towards sustainability here at the Health Sciences Center, and the kind of linguistic equity and competence that that we need and must be part of what we provide in services to those we serve. So thank you so much for being here again, and very excited about the summit, but, you know, and as importantly about the outcomes of this. So I will turn it over to my colleague, Dr. Fabian Armigo. Thank you.
Thank you, Dr. Romero-Leggett. Hi, everybody. As you heard in my intro from Dr. Parajon, I'm the Executive Director for Diversity, Equity, and Inclusion for UNM Hospital. And my first job at UNM was medical interpreter. So I'm excited to be here to just share a little bit about what that department does, because I still have responsibility over it. So in 2004, the hospital was in trouble for not providing appropriate language access. We didn't have a big enough team. So in 2005, as you saw in Dr. Romero-Leggett's slide, the expansion of the Interpreter Language Services Department happened. So, you know, we'll talk a little bit more about what the team looks like today, but I wanted to share this information with you all. These are our top 10 languages that we see. And this data comes from our external vendors, so not from the internal staff at the hospital, but it's pretty much, it reflects the languages that we represent in the department too. So number one is Spanish. By far, it's the language that we provide the most services in. Vietnamese is number 2 on the list. Number 3 surprises a lot of people, Swahili. We have a lot of patients that come to us from the Democratic Republic of the Congo, and that's our 3rd most highly requested language. Then we have Iraqi Arabic, and number 5 is Dari and Farsi, and I kind of lumped the 2 together because a lot of our patients from most of our patients are from Afghanistan, and they speak Dari, but Farsi is a more commonly recognized language, so that data kind of gets mixed together. And then as we kind of go down, we see Navajo, Mandarin Chinese, Kinyarwanda, Cantonese Chinese, and Kirundi. So that's surprising to a lot of people to see that those are our top 10 languages. But since we're celebrating National Hispanic Heritage Month, I wanted to just put this in to put some context with it, where you can really see the number of Spanish services that we provide at UNF Hospital compared to our other top languages. And this is just going from January to June. So the team today, we have 1 full-time Spanish translator, meaning that person is just responsible for translating documents from English into Spanish. We have a program coordinator who helps us with our translation accounts. So when somebody in the health system wants a document in Farsi, we can do that through our external vendors. We have 25 full-time Spanish interpreter and translators. So these people do both interpreting, which is rendering the oral message into English and Spanish and back and forth, and also the written piece, which is translation. We have 3 Vietnamese interpreter translators, 2 Navajo interpreters, 3 American Sign Language interpreters, a department secretary, 2 supervisors, and a manager. And all of our administrative team are trained and qualified interpreters, which I think is really unique and something that we're proud of at our institution, is that everybody in the leadership chain, including myself, are all trained interpreters. So you see that we have an Italian interpreter on the team, a French interpreter, and the rest are Spanish in our admin team. We also have a dual role program. So this means that these are healthcare workers that work in different areas of the hospital that are also trained interpreters. 108 of them are Spanish out of the 128 total. And then you can kind of see the other languages that we have. We continue to work to better serve our Native American communities. So you'll see here we have our first Zuni interpreter. We have 2 dual role interpreters in addition to our 2 full-time interpreters. But we're continuing to work more with Pueblos, the Pueblo governors, to have more representation of those languages. And then just quickly, we have in-person interpreters 24/7 in Spanish and then 24/7 in Navajo. They're not always in person, but they are remote. They work from home or on the phone. We have special services for deaf and deaf plus patients. I think it's important that we remember that not all Hispanics, you can be deaf and be Hispanic, right? So we do serve a lot of Hispanic deaf patients, and we do that through our internal staff and with our external vendors. And then we have these 3 companies that we work with, Pacific Interpreters. They handle most of our interpreter services. We recently have updated the process with the PBX operators in response to COVID. We saw that a lot of patients that were inpatient, they were alone on the floors, and when their family members would try to call and get updates, a lot of times they were getting hung up on. If they got to the unit, they got transferred to the unit by the operator, and the person didn't speak Spanish. So they were getting hung up on, and also it puts the clinical staff in a position to have to stop what they're doing, get an interpreter. So we've changed that process, where now when the patient calls the main number to the hospital, and this is only for Spanish at the moment, we connect them with an interpreter first. That interpreter then connects them with the operator, and they go off to the unit with the interpreter already ready. So this helps nurses and doctors and everybody it saves time because the interpreter is already there for them, which was a big success. So that's one of the things that COVID taught us. And then we have this another local agency, the Community Outreach Program for the Deaf. They offer language services in American Sign Language, but also there are people who can provide Mexican Sign Language. And then HCIN it's an interpreter network where all of the interpreters on this network work in a hospital. So we share our interpreters with Kaiser Permanente. They use ours, Contra Costa. All over the country, we have an interpreter share. And then the last slide I just want to share is where we're going. So we want to continue to add additional phone trees like the one I mentioned. That service is called Newsline Direct Response, where the interpreter gets transferred with the patient from the very beginning. We are working actively on discharge instructions in Spanish. So we are partnering with our colleagues at HSC and IT informatics and nurses. We have a task force trying to put together a way to provide discharge instructions in Spanish to our patients. opt-in fluency tests for clinicians. And Dr. Romero Leggett mentioned the work that's happened with the proposal. So we're continuing to work on that. And we're hoping that people who are bilingual would like to go through testing to prove those skills, we can start to do that. We're piloting that. Expansion of languages represented by UNMH staff. So again, with the Pueblo languages, we have a lot of staff. We employ a diverse staff at UNM Hospital. And we want to make sure that if people are bilingual and they would be interested in providing this kind of a service, that we're making that available to them. The reason why it hasn't happened yet, and I'll just share this quickly, is that the Pueblo governors determine that we rely on them to tell us who can speak these languages fluently. So without their collaboration and help, we don't know, we won't be able to prove that somebody is fluent in their language without that collaboration. So far we've worked with Kiwa Pueblo and the Zuni Pueblo on that. So we'll be adding carries to the list soon. And then the next thing we want to continue to do is streamlining processes for accessing phone interpreters. So for those of you who have used interpreter services, you will be asked for an access code, where we got rid of that. So you shouldn't be asked for an access code. I hope that makes it easier for clinical staff. We've also kind of streamlined the process where there's only one, soon there will be only one phone number. You'll call 2Talk if you're an UNMH employee, 272-Talk. That will connect you with either a phone interpreter or internal interpreters, especially for Navajo, because we really provide most of that service in-house. And then also things like a language line app where doctors and nurses can pull up and any provider can pull up their phone and access an interpreter with one touch of an app. So anyway, that's all that I have to share with you. I'm excited to be a part of this summit, and I'm happy to see so many people on the call. And I know that there's people with Dr. Sanchez in person. And I hope that you enjoy this. And thank you again for everyone that put this together, and thanks for including me in it.
Thank you so much. We really appreciate all that you guys are doing, your leadership, Dr. Romero Leggett, Dr. JP Sanchez, and Mr. Armigo. Thank you for everything you're doing. We next have another speaker we would like to present, and I'm going to ask Dr. Belmonte to please connect and present us with our next speaker. Thank you so much for attending this first part of the opening remarks.
Hello, everybody. I just want to get a thumbs up if you guys could hear me.
Yes, we can hear.
Excellent. Yay, this worked out pretty well. First of all, let's, what we're going to do is, the underlying theme of the morning is actually, if you ask me, it's technical difficulties. And if you ask enough, how many MDs does it require to set up a Zoom session? It's apparently too many. I'm going to give a little time for people to kind of get moved over here in person, because we have a good size of people here. It's probably going to be best if the people in person move over to this location. But this is what I'm going to do. I'm going to go ahead and get started. Hello, everybody. My name is Alfonso Belmonte. I am currently speaking under an amazing PA student's account, Gabriela Marin Villalobos, a personal friend of mine who actually saved the day. So for this next hour, we're going to talk about the need for Spanish-speaking health professionals. And the framework that I decided to use was mente y corazón. This is going to become a little more clear with time what I mean by that. So for the first 30 minutes, we have an esteemed guest, Dr. Alicia Fernandez from UCSF. She's going to kind of give us data and hard facts and review the literature on why is it important to have Spanish-speaking professionals. And then for the next 30 minutes, we're going to have a panel of healthcare professionals, ranging from pharmacists to physician, resident physician, and one of our nurses. And we're going to share stories. And hopefully those stories impact our heart and have us realize, round out our understanding of why this is so important. So for this first 30 minutes, I'm honored to introduce Dr. Alicia Fernandez. She is a professor of medicine at UCSF and a general internist at Zuckerberg San Francisco General Hospital. She is the founding director of the UCSF Latinx Center of Excellence and a HRSA and UCSF funded initiative to increase academic diversity. Dr. Fernandez directs the Latinx and Immigrant Health Research Program at UCSF Center for Vulnerable Populations, which generates actionable research to increase health equity and reduce health disparities in at-risk populations in the San Francisco Bay Area, California, and nationally. And effective July of this year, congratulations, Dr. Fernandez. She is the Associate Dean of Population Health and Health Equity at UCSF. Dr. Fernandez's research expertise includes language and literacy barriers in healthcare and healthcare equity in chronic disease and racism in medicine. With that, I'd like to turn over the screen to Dr. Alicia Fernandez. Let me stop sharing.
Thank you so much for that lovely introduction, Dr. Belmonte. And I want to begin by saying to everyone how happy I am to be here. I'm honored to be asked. And I want to specifically thank Dr. Belmonte and Dr. Sanchez. They were both extremely patient with me as I worked out some conflicts and other sort of logistical issues. I'm very involved in our COVID response, and it's been we're still quite busy. I'm really I'm really happy to be here. And before I forget, Dr. Sanchez, again, thank you so much for inviting me. And I want you to know that I am also an Einstein alumna. So we have that in common. What I thought I would do today is just a quick overview of where I think we are with some of our language research, and really looking forward to the panel and your questions and answers. So let's see, and participating with the other folks. I'm gonna share the screen. Let's see how many ways I can figure out to make this, whoops, wrong talk. Sorry, I apologize. New Mexico, there we go. Can you all see my screen okay?
We sure can.
Great, perfect. All right. So I have no disclosures. This is a photo from the Times. It was about, wow, almost 4 years ago now. And this is, these are Syrian refugees crossing into Turkey. And this is a photo from the southern border, also around pre-COVID, about 3 years ago. Why do I show these photos? To remind myself and everyone that people are on the move more than in any other time in global history. And that when we talk about language barriers, while we tend to experience that very locally, this is a global phenomenon in healthcare all over the world. But in no country is it as much a phenomenon as the United States. This purple line here, these are destination countries and this purple line here is the United States. The United States has more than 50 million foreign-born folks. And you can see the increases here in Spain and South Africa and Mexico, but they pale beyond, they pale in comparison to the United States. When we look at the United States, we see that about 78% of the population speaks English, and about 13% speak Spanish, 41 million people. All other languages pale in number compared to Spanish. So that even though the census lumps the Chinese languages together, Mandarin, Cantonese, etc., all of the Chinese languages together are only 3.5 million people. And you can see there the next most common languages in the US nationally. So why is this? I think you all know well, but I enjoy showing these slides. This is a CDC slide, which shows us where the Latino population was. And I know you say Hispanic, but I'm used to saying Latino, so that's what's gonna come out. Where the Latino population was in 1980. 1980 wasn't that long ago, but at that point, the Latino population was only 6.4%. And here in the different shades of purple show the Latino population as a percent of the county population, with the deep purple showing counties with 25% or more. I'm going to advance the slides in time. This is 1990, and we see more extension and more, tends to be around the gateway areas. And now 2000, and we see much larger proportions, and here the proportion is 12.5. 2006, 14% of the population, and you see purple throughout the country. They changed their slides, and now it's 16.3. And what's important to note here is that the deep purple now denotes counties that are more than 50% Latino. This is 2006, and oops, wrong direction. And this is 2010, and the latest census data have just come out, and the population is between 18 and 19%. And you can see what I want to point out here is how deeply purple, not how deeply, but how broad spread the purple is throughout the country. There are very few areas in the United States now that don't have Latinos, and for that matter, Spanish-speaking only Latinos. 2014. So one easy way to remember this is using the census question, how well do you speak English? Very well, well, or none. About a quarter of Latinos speak only English. About a quarter speak only Spanish, which is to say, sorry about that, they answer the census question that they speak not well or none for English. And then about 50% have some degree of bilinguality. And what we don't know there is how bilingual they are in Spanish. We know that they answer the English questions as that they speak English very well or well. So summing up, 3/4 of Latinos speak English very well or well, and about 1/4 does not, about 11 million people. So the first issue in language access is the incredible underuse of interpreters. We don't have good data on this nationally. In fact, I have never seen a national study looking at this from the point of view of the healthcare system. In national data, when you ask patients if they were provided an interpreter when they needed one, believe it or not, the last national study I saw was about 10 years ago, and they still are reporting 3 to 4% of people saying, yes, they were provided an interpreter. This is a study that we did looking at informed consent. And what we looked at was thoracentesis, LPs, and paracentesis in our hospital. All of these require a form. We have forms in our 5 most common languages in addition to English. And we looked at documentation of informed consent. And what we found was that while we had a long ways to go with English in terms of making sure that we had appropriate documentation, a procedure note plus a consent form. In the patient, for LEP patients, the informed consent was half. The hospital has repeated this study many times. We have done this. We have carried on a fair amount of quality improvement activities, and we are doing better. But nonetheless, our other UCSF, we have 3 main teaching hospitals. Our other UCSF hospital was cited a few years ago, again, for our private hospital, voluntary hospital, sorry, was cited for not having, for insufficient documentation of informed consent for patients who do not speak English. We can talk more about this. This is a useful study to repeat locally, though it obviously raises. I think that whenever you discuss healthcare disparities, it's good to know that you are being transparent about your own. So what's up with that? We have great residents. We have great interpreter systems certainly at San Francisco General, which is where I work. That's ever since the 80s has a very robust interpreter system. So we did a study, a qualitative study with our residents and with residents at Yale New Haven to ask them, why don't they use interpreters more consistently? And what was interesting to me about the results is that the residents explained that they made an explicit decision. They were like, how important is this conversation? If it was very important, a high stakes conversation, chemotherapy, no chemotherapy, anticoagulation, no anticoagulation, they called an interpreter. But if they called it routine medical care, then they weighed the hassle factor versus, quote, getting by. I'll show you what they mean by that. And what they also explained to us is that, they knew that it was okay that they could essentially, that it was normalized in their environment, not to use an interpreter. And I put this here because it makes my family proud whenever I say this is my only article featured in the New York Times. So the MDs, so the residents used to say things like this. I know that when people are very pushed for time, they may or may not call an interpreter. They may just get by on the few words they know in a different language for pain and take a deep breath and just fumble through. You probably get a pretty bad history and maybe not a great physical exam either. And things like this, I hate to say it, but interacting with an interpreter doesn't bother me too much. I guess I feel like someone is talking to him and getting a good history at some point. So it's okay if I kind of come in and do a little bit more of a perfunctory exam in history, knowing that I will at some point talk to them with an interpreter when time is available. But in some ways, it does not seem all that fair because English-speaking patients, I talk to them in their own language easily, even on call, even when I'm busy. Now, some of you may have noticed the date on that, and that was a while back, that study. We repeated it in 2014, looking at specific instances. And here, the blue is when people use only a professional interpreter. And what we found is that people, 60% did that on admission, 85% did it with procedural consents, which is to say that 15% did not. 73% did it for family meetings, and only 60% did it at the point of discharge. And I want to come back to that because of what I heard you all saying about discharge, which is obviously a safe discharge being the goal of medical encounters. Really interesting to note that fewer than half of our residents report using professional interpreters in daily rounds. And you'll see that I come back to that theme when I talk about our asks of our own institution. So in summary, and we then repeated this right before the pandemic and on our hospitalist survey, and we got service, and we got this very similar results. So number one issue is that underuse of interpreters is common and often normalized. And I should, just to be sure that we're all on the same page, point out that San Francisco is an extraordinarily diverse city. We have many, many languages and many patients that need interpreters. So it is really an issue on our services. Second issue, which relates to the theme of language concordance, is that interpreted conversations often result in suboptimal communication. This study is not mine. This study came out of Bellevue, but I like this study a lot because it's in a certain way the nearest thing that we have to an RCT. Let me explain. At Bellevue, the Safety Net Hospital in New York, highly diverse patient population. And what the investigators was interested in were comparing two state-of-the-art interpreter systems, one in which the interpreter came to the bedside and one in which they used UN-style remote interpretation and simultaneous as the person was speaking. So as a patient would come into the ED, If they happened to be assigned to a doctor that spoke their language, then they were in this category, language concordant MD. And otherwise, they were randomized to one or the other interpreter system. As the patients left the ED, they were all patients were asked questions. And here's what I want to point out. The patients reporting that they understood the MD explanation was 60% of those who saw the language concordant MD, and fewer than 40% of people using the state-of-the-art interpreters. Similarly, understanding instructions for what to do with their illness, it's about 60 compared to under 40. This is an enormous gap. It bears mentioning that 60% understanding the language concordant MD isn't great either, but it's a lot better. And of course, Bellevue is like my own hospital, a safety net hospital. We take care of poor patients with low education level, and we're working across literacy language barriers at the same time as we're working across language barriers. But nonetheless, this is really a very large difference in comprehension between interpreters and language concordant. Following on that study, my team did a study looking at patients in the Kaiser Permanente system. And here we were looking at Latinos who were either English proficient or LAP. And we asked about trust in their primary care doctor. And about 25% said, we don't really trust our doctor. That's interesting. But when you disaggregate the LAP by whether or not their doctor is language concordant, 60% do. The number drops to 16%, whereas the discordant number is 35%, which is to say that 1 in 3 of the patients who had their primary care doctor not speaking Spanish expressed a lack of trust. These are very good doctors. The Kaiser system obviously has interpreters, and people are required to use it. And it speaks to what others have found as well, how difficult it is to establish trust across a language barrier. Many more felt treated poorly because of language, and again, many of the discordant patients felt that the physician did not show them respect. The only domain in which language was not a barrier is that about 1/3 of our patients think that we don't listen to them, irrespective of what language we speak as doctors. So, to some, language barriers are associated with less trust, less comprehension, worse patient satisfaction, and less patient-centered communication. And I want to say a word about less patient-centered communication. There are some really great studies where people have videotaped or audio taped interpreted discussions. And what happens in those discussions is that two things happen. One is that the patients speak less than they do in language concordant discussion. And they specifically ask less questions, or their values are elicited, what they think is elicited less often. And very important, and I think germane to the issue of trust, is that patients, we have many more empathy gaps. Let me give you an example. So this is a typical I precept in our clinic, and sometimes I'm in there and say the resident is talking to a patient in Cantonese, and using an interpreter, the resident says to the patient, I see you missed your appointment with the diabetes nurse. Patient answers, yes, my mother was in the hospital. Resident says, okay, I'll make you a new appointment. So what happened there? Are our residents, bad doctors? No, they're great. What happened there is that the resident is so focused, just like I am, making sure that I get everything done, making sure that the Cantonese speaking patient understands, use a metformin twice a day, use a statin once a day, that I become less patient-centered, less like, oh, your mother was in the hospital. I'm sorry to hear that. I hope she's better now. The sort of thing that I would normally say without thinking to a patient with whom I share a language, I forget to say with an interpreter. And those empathy gaps, which, by the way, are what happen in racially discordant relationships. That's the thing that's been one of the things that's been seen in, say, Black-white interactions. These empathy gaps are, I think, what really make people feel untrusting, that they're not cared for. It's not the only thing, of course, but it's one of the things that contribute. So again, difficult to have patient-centered communication through an interpreter. And then I'm not going to go through all the data. You can see the references, but there's more medication errors, difficulty understanding prescription labels, not knowing the medications with hospital discharges, and so on. We have a system in place where patients upon discharge, I think it's 5 days after discharge, are called to make sure that they were able to obtain their medications, know their medications, and have a follow-up appointment. And LEP patients are much more likely to say, I don't know my medications, I don't know what I need to do next. Still, that's now. Let me tell you about another study I did at Kaiser, where we looked at a large number of patients. And here we looked at English Latinos and LEP Latinos, and to make who are similar with respect to clinical characteristics, age, and so on, but quite different with respect to education, as you would imagine, with 70% of the English speakers having a high school degree or above, and about 70% of the LEPs, Latinos, not having high school. And then we disaggregated again the LEP Latinos by language concordant and language discordant. And those, the p-values there were all essentially non-significant, showing it almost looked like randomly distribution between the concordant for these Latino patients between doctors that spoke their language and doctors that did not. And when we looked at their glycemic control, we were looking at glycemic control over 9, clear-cut, poor control. Only about 10% of the English-speaking Latino white patients had such poor control. 18% of the Latino English speakers did, and 21% of the LEP Latinos did. Big differences, all significant. When we disaggregate by language concordance, that the LEP with a language concordant do as well as the Latino English speakers, whereas the LEP with a non-Spanish speaking doctor do much more poorly. So this was very interesting. And what this said to us is, wow, discordance appears to be really and truly associated with worse glycemic control in this population of patients with diabetes. And it's important that this was done at Kaiser because this is about as good as it gets in terms of ease of care. It's an integrated healthcare system, obviously, with a lot of support, a lot of interpreters, and so on and so forth. So then we said, all right, is that true of other outcomes for these patients with diabetes? And it turned out not to be the case. It turned out that for LDL, there were differences, but they were small. The white patients, about a third of them, 33% had an LDL over 100, and about 36%. And while this was different, it's not huge. The Latinos tended to do about the same, regardless of the English of their doctor's Spanish level, and that was true for their for blood pressure as well. So isn't that was very interesting to us. It looks like that when you look at glycemic control, obviously highly complex interactions between diet, exercise, medication use, etc., there were very large differences. But when you look at something that is relatively simple, statins are so powerful that if we can get our patients to take a statin, that's it. You know, they're going to be pretty controlled. It was, we did not see these large differences, and similarly for blood pressure. Well, the skeptics can say, okay, interesting, but this was a cross-sectional study. What we really need is an RCT. Okay, let's do an RCT. But the problem is that you cannot do an RCT because the literature is so, first of all, you wouldn't be able to recruit patients to being placed with a Spanish-speaking doctor or not, because patients so prefer a Spanish-speaking doctor. Second, the evidence is really clear-cut that the patient experience is better. So I don't think one would have equipoise. So we said, okay, let's look at a natural experiment. And what we did is we looked at switches, people who switch doctors. And when we look at switches from discordant to discordant, from concordant to discordant, et cetera, we looked at their hemoglobin A1C 1 year after they switched. And what we found is that when the only thing that made a difference was switching from a language discordant doctor to a language concordant doctor. When people did that, they were much more likely to end up, this is prevalence, so much, 13 points more likely to end up in, to have glycemic, relatively good glycemic control, and less likely to have poor glycemic control. So this was really telling, and I'm not going to show you the adjusted models, but it held up with all of our adjustments. And then we said, okay, let's only look at a subset of patients where the doctor has left Kaiser. In other words, there is no way the patient could have initiated the switch. It's the doctor leaving that prompted the switch. And the results held true. The point estimates were the same, though the confidence intervals overlapped because the sample was small. I hope that's being clear. And do feel free to put any questions in the chat or interrupt me or however you want. So then we were thinking, okay, very interesting. How does concordance work? And what is it about, how is it working clinically? And so we thought we would, again, using Kaiser data, because Kaiser supplies their own medications, we're able to look at refill data and we're able to see good measures of adherence. So what we found is we had a measure, we used a nationally accepted measure of inadequate adherence, which has to do with missing more than 20% of your medication days. And what we found is that we're looking only at oral hypoglycemics. It's too difficult to look at insulin use because, obviously you can tell the patient over the phone, give yourself more insulin or less insulin. So it's too difficult. This is oral meds. And what we found is that among whites, 37% had poor adherence. Among English-speaking Latinos, that number went up a lot to 51%. And among LEP Latinos, it was 60%. This is not an insurance issue. These are all people who were consistently and constantly insured by Kaiser. And then when we separated those patients by the language of their physician, we found no difference. So that's interesting. We show on one hand difference between glycemic control, but we find no difference in use of oral, in adherence to oral hypoglycemia. And what we think is happening here, though we don't have, it's too hard to sort out, is that more people are less afraid of insulin and are using insulin better when they have a language concordant doctor. And also that'll be going back to this issue of patient-centeredness, that a language concordant doctor is more able to do and more to do the type of diet and exercise counseling that is so important within diabetes control. And so again, very important. People sometimes ask me, are these doctors Latinos or are they non-Latinos who speak Spanish? The bulk of these doctors are also Latinos. We're not able to really sort out, but language and culture. but I think that those physicians are much more able to, they ask more of the right questions. Like in my case, asking how much soda are you drinking? Are you drinking licuados? Are you drinking horchata? Are you drinking agua fresca? Then we are and much more able to do the counseling for complex that is necessitated. So in summary, not only is underuse of interpreted conversations very common, interpreted conversations tend to can result in suboptimal communication because comprehension, trust, and satisfaction are all impacted. And complex care, not all care, but complex care clearly benefits from language concordance. And one of the areas of research that really needs to be built out is understanding that better for the researchers among you, or for what are the areas where it really really matters. And then finally, what I take from this, and what is part of my own practice, is that often I will call a consult of a language concordant doc, either on the wards or even have sent my patients in outpatient for 1-time or 2-time consultation when it's necessary for sensitive discussions, for things that I'm concerned, and I know that I'm going to miss the language cues and I'm going to miss the cultural cues, or even on the wards for certain exams, like exams around altered mental status, around psychiatric disease, or dysarthria. So this is all things that we need to work on. The other thing it's done is really has helped me focus my own work when I'm working with interpreters, is it's made me much more intentional, recognizing that these things are impacted. What we now teach our residents is to always use some form of teach back or other assessment of comprehension, because again, you saw the data out of Bellevue. To intentionally make multiple empathic statements, to build trust, intentionally try to build the trust, and to be very intentional about eliciting the patient's point of view, particularly with respect to the instructions that you're giving them. Because again, so focused on you should take this medicine and do this, that I neglect to ask my patients, say my Cantonese or Hindi speaking patients, what do you think of this plan to take this medicine in these ways? I also use this slide to remind me to talk about training. Training clinicians to work with interpreters clearly helps. Clinicians who have been trained report a lot more ability to elicit symptoms and to elicit the patient's point of view. And one of the things that we are working on for our own institution is trying to ensure that our clinicians are trained. And then I want to briefly mention technology, that it is that we have been working, we've done a study with Google Translate, and Google Translate is actually, if you use it, we looked at ED instructions, and for patients, and in Spanish, it is pretty good enough that you can use it as long as you keep your language simple, and as long as you don't use medical jargon. So we are now allowing and we looked at Chinese as well, and it was not as good, but it was okay. And so what we're doing now is we allow our residents to use Google Translate, but we require as a best practice that we use Google Translate in Spanish, that we put the English right underneath it. And then there's a line, a dot phrase that's inserted that said, this was accomplished by machine interpretation. The English is correct. So think about, I don't know if that's useful in your own work. And this is where we are in our institutional asks. We are trying to gather language data properly. In other words, not only asking about language preference, but also asking about English proficiency. We're trying to run our quality improvement data by LEP status. We are gathering language proficiency of our clinicians. And what we're doing is that we are asking clinicians who do not want to use an interpreter to take an exam. The hospital does pay for that exam through its ALTA language exam. And we are certifying people as bilingual clinicians or bilingual staff. It is a slow process. All of our students must take the exams before they come onto the ward. So at least we'll have that. And we're asking for additional pay for bilingual clinicians and staff. That is true for our residents when they rotate at one of our hospitals, but not in our other hospitals. We are asking that all hospitalized patients have to document one conversation per day with a physician, either via an interpreter or via a language concordant doctor. You would think that this would be a no-brainer. It has in fact been a very difficult ask, and people are resisting it because of the added documentation burden, though no one disagrees that this is an actual problem. But we now have a pilot in place among our internal medicine hospitalist service. We're also asking for one conversation per 12-hour nursing shift, meaning that the nurses must document one conversation. Again, lots of resistance at our voluntary hospital for the documentation requirement. We are continuing to survey patients at discharge to see how well they experience language access. And about 15 to 20% of our LEP patients complain about language access, even though they are normally, of course, very grateful for the care that they have received. We are trying to train more of our clinicians and interpreter use. With COVID. This has all gone by the wayside. Everyone has been doing only COVID, and we're monitoring our informed consent discussion. So many similar things to the things that I saw you all working on, and we can sort of talk more about that if interested. So with that, let me stop here and say again, a privilege to get to participate, and I look forward to the discussion. Thank you.
Thank you, Dr. Fernandez. Let me take up some time here. A little bit of a lag. So really quickly, we're going to talk about some stories, and to kind of get to the heart, I'm going to ask my two participating people to come towards the front. And we will modify I think probably if you stood, that would actually probably be best. Yeah, stood right in front of me. That would actually be really good. Okay. Actually, we can move the camera around. That'll be fine. Okay, so we're going to go addressing the story. I'd like to quickly introduce the concept of Spanish abilities as a spectrum. I want us to recognize that some of us had to reclaim that Spanish ability. Some of us had to reclaim it from racist institutions that have systematically taken it away from us. Some of us had to reclaim it because of protective parents who didn't want us to suffer ramifications of being punished at schools. Some of us are fluent and it's actually our first language. So there's a spectrum of Spanish abilities, and I want to acknowledge that, and I want to acknowledge that doesn't take away from your identity as an LHS plus person. So I just want to acknowledge that up front. Quickly, our panel is Dr. Alicia Fernandez. Dr. Lorena Cordova de Ortega is a professor and chair in pediatrics. Dr. Krista Salazar is a pharmacist and a clinician pharmacist, and she's an associate professor with pharmacy here at UNF. Mirna Nunez Romero is a pediatric nurse on the GPU, the General Pediatrics Unit, and a nurse practitioner. And then Dr. Lorena Galvan is a pediatric resident physician, and Dr. Cristian Solis is a neurology resident physician. So the first question is actually for Dr. Loreta Cordova de Ortega. Tell me about a time or times when you realized the patient received substandard care because of English-Spanish language barrier between provider and patient.
Sure. I'm a pediatrician, I'm a general pediatrician, and my passion is to take care of children with special health care needs. So these are patients who have complex medical conditions. And there's a specialty of understanding where they're coming from, and the expectation that these parents are required to do a lot of home care on their own. And so I was really pleased to be able to work with these families and help them understand the complexity of the care and really them becoming proficient in the care of their children. And so one of the things that I recognized early on was how much these parents knew and how we had to listen to the parents to understand what was going on with their child because they could tell the story. And so over and over again, what I was experiencing, so this isn't just one patient, it's multiple patients, that they would get sick and our avenue was to go to the emergency room to be seen, to be cared for, and then made a follow-up appointment later. And I have been here at UNM for 30 years, so these are stories from early on. And my patients would go, and this is before we had a pediatric emergency room, is where kids were seen in the general practice too. And so my patients would show up and try to explain what was happening to their child, and they would just get a lot of labs done and sent home. And so the families would call me or make an appointment to get in to see me. And their appointment was, I don't understand what they were telling me. I was worried about my child. Their G-tube wasn't working, or different things like that. Their tracheostomy wasn't working. And I tried to explain to them what I did at home. And oftentimes I was criticized by that I didn't know about the care of my child. So a lot of those stories happened a lot. Ultimately, what I ended up doing was giving the patients my cell phone number. And they would call me to explain to me what was going on. And then I would facilitate their visit to the clinic or to the emergency room and to give direction to providers to help that. So it's really a general experience, but certainly one that I felt very concerned that they weren't getting care and they weren't getting the respect they desired, that they not desired, but desired, because they had the experience of taking care of their children. So that is a very general one, but very commonplace that I saw in my practice.
But then I couldn't resist but to talk a little bit, even though I'm the moderator, I inserted myself here because I had such a pertinent story recently. Child from New Mexico, family from New Mexico, Spanish-speaking family, went on vacation to another state. In another state, he developed severe abdominal pain, went to an emergency department, was appropriately, in my opinion, diagnosed appropriately, and initially stabilized. And that initial medical encounter was with an interpreter. Family very much said that they understood everything that happened at the beginning. That's where the problem started. From what I can gather from the family telling me is that in this other location, they wanted to transfer to the local children's hospital, but there were no beds available. And a lot of the subsequent conversations happened intermittently with an interpreter. And what the family perceived was, we can't help you any further. We don't have inpatient care. You're gonna have to go drive to some other location for help. And what the mother perceived was, here's a paper, sign it and go. This mother put her child in the car, drove from the other state overnight, her husband and her taking turns so that they could sleep with their child moaning in pain in the back. It came here and it was admitted to our inpatient peds unit. When I was able to get the documentation, essentially it was this family signed out AMA, but this mother did not understood what AMA was. She just put a paper in front of her and said, sign it and go find care. That was her interpretation because she didn't have an interpreter for those last pieces. And it just really brings up the point that all of our communication, the administrative side is incredibly important to have interpreters with, not just that medical provider relationship. So that's going to be incredibly important going forward, is that we understand that all of those interactions are really important. And I just remember the little boy said, aquí si nos entienden, aquí si nos ayudan. Here they can understand me, here they can help me. And so that was just a really important point where whether or not the communication happened like mom or they said it was probably a mixture of the two, it doesn't matter. The family perceived that they could no longer be helped at that institution. So I think that was a really important learning point. Whoops. Let's go to the next question. This question is for Dr. Lorena and Dr. Cristian Solis. Being bilingual is like having a superpower, but with superpowers comes great responsibility and need. Tell me about a time when your Spanish skills were needed to improve patient care, and I'm sure you were happy to do it, but also at the same time, it created an extra responsibility on you that other learners did not have. And I'll have Dr. Galvar go first, please.
Can you hear me?
Yes.
So this happened in the newborn nursery, my intern year. We had a mother, undocumented Spanish speaking, who disclosed she was experiencing domestic violence in the household. And it was a very difficult situation because the partner had threatened to deport her if she ever reported. And so during the course of the time that we were caring for her, I was specifically assigned to interpret for a social worker. So whenever the partner left the room, we would sneak in, talk with the mom. I would interpret for the social worker, and then we would step out. And I found that as time went by, we found that a lot of the resources that we had were in English and not in Spanish. So I had to translate and look for resources in Spanish for this patient as well. And it was, in the end, I felt like this was one of the most meaningful, impactful patient encounters of my entire career. And I felt as though it wasn't just my Spanish skills, but my cultural background, my identity as a Latinx woman that helped that mother to develop trust in us. And eventually she did report the partner, and we did provide her with resources. And my senior resident also was able to get a connector with an immigration lawyer as well. And even though this was such an impactful patient encounter, and we delivered phenomenal patient care, I feel like it also shows that what a lot of my colleagues don't recognize is that when a system has gaps in providing care for patients, equitable care for patients that don't speak English, we feel the responsibility to have to step in and fill in those gaps and interpret and translate and do other services, as well as be a really great doctor for that one patient and for all the other patients on the floor. And I think this experience encompasses that, which a lot of my colleagues don't recognize.
Thank you for sharing that story, Dr. Galvan. Dr. Solis.
Hello, everyone. Good morning. So, being a neurology resident puts you in a pretty unique, very unique situation sometimes, even in the middle of the night, given that there are a lot of neurologic emergencies in this state, and given that we're the only neuroscience ICU in this state, we're now a comprehensive stroke center. There have been a dozen times that I can think of where, my ability to speak Spanish, really moved the conversation forward, whether it was in regards to a patient, being a TPA candidate in particular, or not being a TPA candidate in particular. As you know, if given outside of 4.5 hours, your bleeding risk skyrockets. And so that's very important, especially in the middle of the night, when patients, either they can't talk to you because of a stroke, or oftentimes what I've seen is either EMTs or other staff will think that a patient can't speak to you because of a stroke, but sometimes it's just a language barrier. And so, as soon as I recognize that, I will switch and start speaking Spanish immediately. Now, the hospital has gotten better, and there is usually an interpreter available, but that is not always the case. I mean, Spanish in-person interpreters are widely needed in the hospital, so they're not always there. Other situations have been, for example, epilepsy patients come into the ED, and oftentimes I've seen it when they come from other hospitals where they have written all over their chart, non-adherence, non-compliance to medications, but nobody actually took the time to sit down with them to figure out why it is that they were not taking the medications as prescribed. I've found that often, and sitting down, talking to them, being able to take those verbal cues and nonverbal cues, given that culture and my first language, has helped tremendously. And then lastly, being on wards, anything from typing up instructions in Spanish has made all the difference. Initially, now there are some templates. However, initially there have not been. And, simple things like anticoagulation, atorvastatin, aspirin, Plavix, these things, or your anti-epileptics, they really matter in the long run. And, we see them acutely in the hospital, and trying to prevent them from coming back into the hospital, is one of the biggest things. And being able to do that is remarkable. Yeah. Thank you.
Thank you, Dr. Solis. I think that's important perspective for all of us to remember, and it doesn't go away once you're attending. If I'm being quite honest, several patients, I'm trying to take care of their admitted patients, and they take the opportunity, because I understand them and we could connect, to talk to me about their child who's at home, who has behavioral issues. And I think that's, we definitely, I think the patients catch on to that when they can connect with us, and we do have that language competence. They take the opportunity to advocate for themselves with the provider who finally understands them. And I think that's really key to understanding our populations. The next question is, there is so much more to great medical care than physician-patient relationship. This question is for Dr. Salazar and Mirna Nunez Romero. Tell me about how the nursing-patient relationship or the pharmacist-patient relationship with language concordance can significantly improve patient care. And I'll have Dr. Salazar go first. If she's on. Okay,
yeah, I'm here. Can you hear me?
I can hear you now. Yep.
All right. Thank you for asking me this question and for having me as part of this panel. I appreciate it. And so you want me to tell you about language concordance and how it can significantly improve patient care. I've seen this in all my 12 years of working at Albuquerque Healthcare for the Homeless. And what it does is it builds connection. It bridges that space that shares our humanity. Because our common language, we can begin to see each other within each other's spaces. And when that happens, empathy is born from that. When we see each other within another person, that's how empathy can become a space. And so in my situation, I manage diabetes. I help patients to manage their diabetes. Diabetes is a very emotional disease state. There has to be lots of connections that are made, and patients are more willing to open up to the things that they're having difficulty with or the things that they feel guilty about. And we can just talk from a platform of shared humanity rather than me talking at them and telling them what they need to do to manage their diabetes better. Thank you.
Thank you.
So I've been a pediatric nurse for about 4.5 years now, and the whole time I've been there, I have noticed a lot that families tend to not say everything to the interpreters. They'll, I think they also focus on what's important, what do I need to ask about this, and kind of leave out, I would say, the emotional things, a lot of different things that later when I'll come in, they say, what is this? They'll mention things that we hadn't, discussed with the interpreter. I think that what I've experienced, even just going into a room and the moment you present yourself and say, hi, like, me llamo Mirna, yo voy a ser tu enfermera, like, you just see people's eyes spark up and they have so much to say that instant moment. They just have all of these different, like, worries, aside from the medical, like their, worries at home with their child, especially with the chronic patients about, small aspects of how they're caring for their child at home and their other kids that are surrounded. So I feel like having that almost cultural humility to, let them know I speak the same language as you, it opens up so many doors for them. And I think it shows them this level of respect that they might not feel when, someone doesn't understand them and they feel like heard, basically.
Excellent. Maybe I'd like to dig just a little bit deeper because I hadn't prepped you for this, but I think it's really important. I think from my side as a physician, it's really easy to put in CBC, CRP, and blood culture. That's really easy to do from this side of things. And then physicians aren't always necessarily the first to go and tell the family, we often tell them you're gonna get labs, but not necessarily what that means, especially a blood culture, right? That means a fresh poke. Tell me how that has, your Spanish skills have really helped you to navigate that side of medicine where you are sometimes the first person to say, I have to do this painful procedure to your child.
Oh yeah, that's very significant because, you go in there directly and say, like, if you have a child who's getting poked every 4 hours, and it would be very difficult, if you just go in like and sign things, which I've seen people do and say, hey, I think it, explaining to them why we're drawing this lab, what is this lab for, and then having also the follow-up, I like to let them know, okay, this is what it looks like now, this is what we want. It also kind of helps them, become more educated in themselves on like, what does this mean? Like, why are we doing this like so often? And especially with kids whose IVs don't draw and you're, going to wake them up every like 4 hours. And I think that just letting them know constantly, which is what I'm grateful that I'm able to do speaking Spanish, adds like a huge factor in their understanding of like, what is this for? Like, it's not insignificant, like we're doing this because of this reason, so.
Yeah. I just, I try to be as big of an advocate as I can for my nursing staff because they're in the front lines and they're the ones doing the painful procedures often where we order. Thank you for sharing that. We'll finish out with Dr. Cordova de Ortega and Dr. Fernandez. I guess it's a two-part question. And it is, how has access over your career, how has access to Spanish-speaking providers and healthcare professionals changed over your career? Is it better or worse? And what advice as administrators in your respective institutions do you give to us, to all of us, as to how to advocate and change our institutions to place even more value on the importance on meeting the linguistic needs of our communities? I'll have Dr. Cordova go first, please.
So as I mentioned, I've been here 30 years. So you can only imagine 30 years ago how few Spanish-speaking providers there were when I started. In our clinic, there were 2 of us. And we had a very busy clinic. We would see 100 patients in a day and through the night. And so I recall when I first started here that paper, not computers, they had paper charts. And people would write on the top of the paper chart Spanish at the top of the chart. Mm-hmm. And when I first started working here, I thought, wow, that's interesting. And I made an observation, and what would you think? Is that chart got ignored for a long, long time. Mm-hmm. People would see that chart and they'd skip it and go to the next chart. And I remember my first week and I said, why do we do this? Oh, well, you speak Spanish, that's for you. Hmm. And I was very proud to be able to take that patient chart and go take care of the patient. But then I started thinking, wait a minute, is it my responsibility or is it all of our responsibility to take care of patients? Certainly, and the answer was, well, the patient will get better care if you see them. And so that was really an acknowledgement at the beginning when I first started working here, that we felt like that language concordance was important. The problem was, it was just 2 of us. And so we had, 20 Spanish-speaking patients. Those Spanish patients would get disparate care because they'd be waiting a lot longer to be seen. So I think that really brought up, well, what do we do about this? And I finally said, this is all of our responsibility. We all have to take care of these patients. And what do we do to help ourselves and each other be able to learn how to take care of these patients? Because we can't have the 2 providers who speak Spanish see these patients all the time. So that was the beginning. And so we took off that label, because also that is labeling people. And what do we think about when we label somebody Spanish speaking? And so it also created some of the learning environment that, there's a disparity already that we're creating. So we undid that and started thinking about, well, what do we need to do? Talk to the institution about how can we get interpreters. We didn't have interpreters back then. And so what do we do? And ultimately, I share this cautiously, but I was on a board, and the board chose to file a complaint against the institution for not having language interpreters. And so that's honestly how things got going. So to answer the second question, advocacy is so important. And that advocacy of people who can help us. We, as an institution, probably were just struggling to figure it out. And it said, we're going to hold you accountable. We would like for you to provide appropriate language interpretation for patients. And from my standpoint here, that was the genesis of our language interpretation services.
Thank you, Dr. Cordova. Dr. Fernandez?
Yeah, thank you. I think that what Dr. Cordova Ortega just shared is very much the experience that that people have had all through the country, which is simultaneously a devaluation of bilingual clinician skills, and also the fact that that many of these things have moved forward very much through lawsuits and through citations, which is really not obviously not something any of us wants, but it is really what's happened. I think things are getting better, but the progress is way too slow. And I think that the way in which I think that one of the things that is getting better is that there are more Latinos in coming into medicine and coming into the health professions. And I think that is key, because it can provide both cultural and language competency. I also think that what is really important is that that there are more institutions like my understanding from what you're saying, like yours, that are trying to help heritage speakers, people like my daughter, whose Spanish is very good when we're saying, have you done your homework and have you brushed your teeth? But will not know how to say your spleen is swollen, because the word spleen has never come up in a domestic conversation. These are heritage speakers, people who have not had formal training. And I think more and more, certainly in the medical schools are instituting courses and are trying to make those available, and then to set an exam so that people can see whether or not they have the skills necessary to be able to work as bilingual clinicians. I think one of the things that I think is really important is for all of us to advocate for a pay bonus. Not because the pay bonus is so important, certainly not at my level of training, at my level now as a full professor, but because I do think that it is part of this devaluation of our skills. When I read an ECG and I say, this is normal, fine, but the cardiologist reads the same ECG and says this is normal, and the cardiologist gets essentially a skill, more reimbursement. It's a skill differential. In the same way, I think it's important for us to advocate for this, for patients, for clinicians and for staff, because I think that it's part of this devaluation of the patient, devaluation of immigrants, and devaluation of the skills that needs to go on. So I guess the most important advice I can give is, one, use local data. A lot of the studies that I showed you around use and underuse of interpreters and the role of bilingual clinicians, these are not, no study is easy to do. All studies are work, but these studies can be done locally, can be published, and is something that I think is really important. So to use data, to come together, to have a comprehensive sort of ask list, which I think is really important. And to have that ask list also privilege our own skills and training and certification, because it's a way of showing that these patients matter and that these skills do matter.
Thank you, Dr. Fernandez. So that actually serves as a great segue to, we're going to skip that because we have to, we're running short on time because we started a little late, but I just want to make a plug for all the subsequent talks. We're going to talk about pain, advocating for clinicians to get paid more. We're going to talk about how to transform our institution to teach our learners more Spanish. So these, all the things that come with the great wisdom and experience of Dr. Cordova and Dr. Fernandez are actually the themes of the subsequent talks. So I invite you all to stay. And I hopefully with this session, we addressed your mind with data. We addressed your heart with stories. And now, as we say in Spanish, manos a la obra. It's time to get to work. Okay? I'm going to turn it over to Dr. David Parajon. And I'm going to ask the people in the room, as Dr. Parajon gets set up, that we all take a picture with Dr. Cordova. And I'd just like to especially thank Dr. Fernandez for all the work and being here. Thank you so much.
Well, I think those last remarks were from my good friend and colleague, Manny De La Rosa, who I know wanted to be here today and was actually going to give this presentation, and he sends his regrets. So with that, we're going to pivot from a discussion quite a bit different from the last session, which was, I think, much more about advocacy and care delivery and the basis for why healthcare has to transform in relation to language, to talking about curriculum, which is kind of to some extent the mechanics of education. Every student, every cohort at the appropriate developmental time, appropriately taught and assessed. So this is going to be quite a different talk, and we're going to talk about the curriculum model we adopted here, how we got there, and how it allows us to link out to other critical curricular areas, including Spanish language instruction. And I hope it'll be interesting. I've been in El Paso since 1996, when it was a regional campus, and it was my great good fortune to have been around when the medical school here was approved and then developed as a separately accredited medical school within the Texas Tech system. And it's been a wild ride. And one of the interesting components to it has been this special curriculum model and the way we're able to integrate topics from a wide variety of areas and do some fresh things, including, I think, a relatively innovative approach to Spanish language instruction in medical school. So if I can get my slide, there we go. So here are our objectives today. We're going to talk about the longitudinal Spanish education program at the Paulo Foster School of Medicine and a little bit about how it's extending out into other aspects of the Texas Tech University Health Sciences Center, El Paso. We're going to describe the resources and funding. We're going to provide some food for thought about how you can compare your own institution's needs and resources to what we've done here and think about next steps. So here is the Paulo Foster School of Medicine. And I just want to emphasize that we're still a very young and developing school. I tell people that we're kind of into a difficult adolescence at this moment as a institution. The school just concluded its inaugural decade in May, so we've been at it for into our 11th year now. And this early phase involved very rapid transformation and growth of a relatively small and dependent clinical branch campus into a completely separately accredited medical school. And it was also the initial step in the development of a separately accredited University Health Sciences Center in El Paso, which was established by the state in 2013, which now also includes a graduate school of biomedical sciences and nursing school, as well as a dental school, which welcomed its first class just this July. The dental school shares some aspects of the medical school curriculum, including incorporation of medical Spanish instruction, but in a slightly different, with a slightly different twist, which I'll allude to at the end. So from the inauguration of our inaugural class of 40 students admitted in the fall of 2009, we have grown to a current enrollment of 425. So here's another view, which I think is very important. It's the view to the south over the main building of the medical school. With the bright red structure in the background, La X being in Ciudad Juarez, Mexico. La X is a monument to those who have suffered and died as a result of border violence in recent years, and is a relatively new and distinct part of the landscape here. But what this shows is the northern end of the western Sierra Madre mountain range, rising behind Ciudad Juarez, Mexico. And the geography is very important because it relates directly to the social and economic challenges which led to the creation of this medical school and that directly affect its mission and curriculum and the inclusion of required longitudinally integrated Spanish language instruction. The population of El Paso is approximately 80% Hispanic, and about half of that Hispanic population preferentially speaks Spanish. The economy of El Paso is based on manufacturing, transnational and interstate trade and warehousing, construction, agriculture, a large military base, and a large service sector. El Paso, relative to other major cities in the United States, has a long history of low median income, limited educational opportunities, low rates of higher educational achievement, and limited access to both primary and specialty health care. Additionally, El Paso, as obviously across the United States, there's a pervasive underrepresentation of Hispanics in the physician workforce. And the Paul L. Foster School of Medicine was created and is uniquely situated to respond to many of these concerns. Let me get lost to my slides here. Sorry. There we go. So here are some demographics relating to our student population. And it needs to be placed in the context of the Texas Medical School applicant pool. If you think about the state of Texas, and I'll show you a map in a moment, the large majority of applicants come from communities along the Dallas, Austin, Houston, and San Antonio corridors, well east of the geographical midpoint of Texas. And so this creates a challenge in recruiting the kind of class that is interested in our mission, in our location, and in our language programs. That said, we are increasingly developing a population that reflects our statewide population to a degree, and we have a significant number of a significant number of folks from the U.S.-Mexico border counties and from El Paso in our classes over the years. For the current class, 23% of our students are from El Paso. 20% are characterized by the TMD SAS, the application service in Texas, as of low socioeconomic status. 30% of our students are from U.S.-Mexico border counties, including counties in New Mexico. 40% are from minority groups traditionally underrepresented in medicine. and 53% of our class is female. So that just gives you a little background on our class demographics and where we're going, even beyond what's shown in the bottom right graph. So here's the state of Texas. And if you can see my cursor, or you can see where San Antonio is right about mid-state, it's actually the geographic center of Texas is to the west of that. And you can see the distribution of medical school academic health center resources as green dots. And you have this whole swath of the state, most of the border region, most of West Texas and the Panhandle are served by only two academic medical centers, one being ours out here in El Paso. And then we couple this with information that we've already touched on in earlier presentations, but this relates to the Texas workforce. And, this is basically a snapshot of where we are with the racial and Hispanic identity of physicians in Texas. And I think points to things that need to change, and also particularly if you relate it to language, that we can't really rely on the physician because of the total population of Texas going back historically in this huge skew. We can't really put the burden of care related to Spanish-speaking patients, obviously, on our small percentage of Hispanic-speaking or our Hispanic physicians of variable bilingual skill. And that's, I think, made obvious when you look at the demographics of Texas and how they have switched, how they have evolved from 2010 to 2020, and then going beyond. If you look at the content here in this slide about where we are with the population of Texas and the significant increases being related to the Hispanic population and the projections for continued growth in the Hispanic population, it's fair to presume that language usage and associated needs in relation to health systems will continue to steeply increase, and that we cannot rely on the small percentage of Hispanic physicians in Texas to meet this need. So now I'm going to swing to kind of more general curricular issues, but we'll get back to why it fits with what we're doing with Spanish language instruction in a few minutes. So there has been a transformation occurring over the last 40 years or 50 years, depending upon how you want to split it, relating to medical education. And it has its roots in the late 20th century with growing public dissatisfaction with a damaged social contract related to the provision of medical care and access to not only care, but education and treatment. And this was abundantly documented in a variety of reports and books that I've mentioned here. And then as far as education, it was confronted by a context of data explosion or information explosion, promoting curricular bloat. We had a historically bound curricular approach that involved a lot of passive strategies and a hard divide between preclinical and clinical study. There's been this increasing awareness that settled principles of adult education were not being applied, and a need to move towards more emphasis on critical reasoning as opposed to memorization, greater emphasis on social awareness and cultural awareness. And beginning back in the 70s, 80s, 90s, and progressively so, or increasingly so, a minority of medical schools began curricular experimentation, and accreditation changes began to shift, or accreditation expectations began to shift in the mid 80s. So this was the context in which, there we go. So this was the context in which an explosion of new schools have developed, and this includes the Paulo Foster School of Medicine. So from 2000 to 2008, there were 6 new LCME accredited medical schools. These are MD programs that opened. The first new school to open in 1982. These were the first new schools to open since 1982. And the Paulo Foster School of Medicine was early in that crowd and featured a fully integrated clinical presentation-based curriculum. Since then, since 2008, there have been several additional LCME schools, and at least 4 of them have also adopted integrated clinical presentation-based curriculums. So where did this come from, and where does it get us in terms of incorporating supplemental or non-traditional content, if you will? This curriculum was brought to us by a original founding dean, Bob Susskind, who was very intrigued by the curriculum that was developed by the University of Calgary around a body systems approach that actually came from an earlier experiment at Case Western. And it basically relied on expert reasoning, on the realization or the acceptance that expert reasoning is domain and subject specific, and becoming an expert in clinical diagnostic reasoning requires broad knowledge of relevant biomedical and psychosocial concepts that need to be integrated in the learner's mind. And that student-directed case-based learning is important, but insufficient to cover the broad scope of general aspects of clinical reasoning. And what they were getting at was that there's essentially an infinite number, or nearly an infinite number, of disease states or diseases identified, but that you can cluster the diagnostic reasoning and integrate content broadly around a more tractable set of modes in which the body responds to these infinite insults or diseases. And this refers to approximately 120 clinical presentations. So what this does is allow reorientation of teaching and learning around a manageable set of diagnostic challenges. And that's really important with the biomedical science and early diagnostic reasoning pieces of medical school. It creates a framework for students to organize their newly acquired knowledge in the context of this broad variety of disease states, but it also facilitates the integrated instruction through learning objectives derived from knowledge and skills required at each step in a diagnostic process for any one of those given clinical presentations. And I'll show some examples of that. So the settled principles of adult learning that were applied in the development of this curriculum were fairly clear and generalizable. Learning in the context of intended application of the newly acquired knowledge and skills. So you want students to learn broadly and integrate around what they need to do to practically perform the job that they intend to take on. This integrated instruction allows the appropriate organization in the learner's mind, as opposed to the siloed discipline-specific course structure in which the student has to take the information that they've learned in the relatively abstract and experimental-based curriculum and then wrap it around clinical problems as they get into the clerkship phase. We had a heavy emphasis on active learning strategies, expert-guided deliberate practice, and then we had essentially a 3 half-day rule in terms of significant blocks of unscheduled time for students to do directed exploration and team learning among their student colleagues. And then frequent formative assessment feedback and a program of spaced repetition of knowledge. And so the pre-clerkship curriculum was broken down into systems-based units that you can see here in this slide for the year 1 curriculum. I'll talk about this SCI /Spanish immersion block and how it fits in a moment. And then using each of these systems-based units, each week of instruction is broken down with instruction based on a common clinical presentation and the decisions that have to be made by the physician when confronted with that clinical presentation in order to end up with a limited differential diagnosis. And then that framework of systems broken down by relevant clinical presentations allows us to link each week of instruction solidly to medical skills instruction on the public health, community health, Spanish language, and principles of public health. And then this course called the Colloquium, which is about the role of, it's a discussion-based course on the role of the physician in medicine, role of the physician in research, and role of the physician in society. And we have a similar structure for the year 2, with, again, more systems-based units that are delivered as 1 week blocks, if you will, driven by a common clinical presentation with integrated instruction across the biomedical sciences, which are represented by the color blocks, plus medical skills, plus public and community health, and the professionalism course. Now, the clinical presentations that we use for that drive each week of instruction are focused on introductory level diagnostic reasoning. So the traditional approach to clinical teaching involving learning a extensive differential diagnosis using deductive reasoning is pretty much has been clearly demonstrated to be fairly opaque and incoherent to beginners. This is kind of exemplified by what happens on rounds, or what you may even see in old medical TV shows like House, in which the experienced clinician asks, poses the question, what might be wrong, and then rattles through a list of 20 or 30 things, and then quickly dissects it down to the 1 or 2 obvious answers, and the medical students and residents kind of stand back in awe. And we would like our learners to get there, but it's as far as using this as a way of launching a medical career and integrating teaching, that type of deductive differential diagnostic approach is not helpful. And what we use are simplified clinical diagnostic schemes that are developed that provide some expert guided diagnostic reasoning, sort of a jump start. And they are hierarchical decision trees, each with a branch point, creating an integrated educational objective opportunity. So, and I'll show you some examples in a moment. And these are supplemented by process worksheets, which are elemental guides. And so here's some example schemes. And for some of these cases, there may be subsidiary schemes, but for each clinical presentation, there's a basic scheme, and it's not so much having the students focus on what's in the boxes, but what's at the branch points. What do they need to ask about? What do they need to look for? What do they potentially need to request a test for in order to make in order to get down to the next level of diagnostic reasoning, and then repeat at the next step. And those questions that are posed at each branch point in the scheme create the learning objectives for the week in terms of the medically relevant biomedical sciences. They also provide, they also inform medical skills instruction. They also provide rich content for asking about public health and community health and psychosocial questions. They also provide the imperative for what needs to be taught in medical Spanish that week. And again, these are supplemented by process worksheets. And so these are just kind of the introductory diagnostic reasoning and motivation for learning pieces for early medical students. And they provide the framework for a fully integrated medical school curriculum, and what we refer to as not the preclinical phase, but the pre-clerkship phase. It's clinical from day one. And as I mentioned before, we use these schemes to pose these questions. What does at each point in the scheme, what do you need to ask about? What do you need to look for? And I put those in red because those create the imperatives for our Spanish instruction for each week when we get to that phase of the curriculum. And what this curricular model is based on is a so-called experiential learning model. And this comes out of what's called the Kolb learning cycle, kind of adapted to medicine by Elizabeth Armstrong and Dr. Parsa Parsi, going back into the early 2000s. And it's this idea that each week of instruction should be initiated with a question. Why do you need to learn this? Well, the clinical presentation provides the why. A patient is going to come to you with X, and this is what you need to know. And then there's this issue of the sessions that follow in the instructional week include a lot of content, so the what. And then as we get into the later stage of the week, it's how do I use what I've just learned in this context? And that's where we again tie in public health, community health, medical Spanish, and the like. And then there's this synthesis that occurs at the end of the week that's case driven. So here's a week of instruction. This is abnormal hemoglobin scheme presentation, maybe not the most thrilling example to use because it's so laboratory based, but it shows basically the first year cycle. And so every week of instruction starts with the clinical context that provides purpose and motivation for learning. Then you get into the curriculum and there's a variety of content-based sessions. What do I need to learn in order to answer those that imperative posed by the clinical presentation? And then we get into more of a abstract conceptualization, how do I use this information? And that's where medical Spanish is incorporated systematically throughout the first 2 years of the curriculum. And that's heavily, the medical Spanish component is heavily linked to the same sorts of things that they'll encounter with standardized patients and case scenarios in their medical skills course. And then there's some discussion-based professionalism coursework at the very end of the week, along with a clinical presentation-based group discussion that integrates what's happened through the week. And there's our extra time, but let's get into the Spanish language curriculum. So, I'm going to go back and talk about this. Every week, there's this medical Spanish instruction, and what this largely fell out of our mission, right? We had this mission of serving the border community. We have this population that is 80% Hispanic, approximately half of that population preferring Spanish. And we were able to leap over these commonly reported barriers showed in this slide because we were a new program in a novel setting with a blank slate. We didn't have a pre-existing college or university. So we were able to design our curriculum very tightly around our mission. But the commonly reported barriers to this sort of program are curricular priorities and bloat. So that goes back to that issue of the information explosion and, oh, no, we don't have room in our curriculum. And then this issue of, well, it's very difficult to teach a subject that isn't tied to admission standards and students coming in with highly variable pre-existing skills. It's way too costly. We don't have the faculty support for this. And there's all these issues with using untrained instructors in medical Spanish or to promote bilingualism. Then the issue of whether you contract or go in-house. And whether it's required or elective. If it's required, you have to deal with student pushback and all these other issues. If it's elective, then you may end up with low retention because of the pressures in medical school that push students in other directions. So, what would I say about how to do this? And I one of the things that was important to us was linking our Spanish curriculum in medical school to our core values. And, our mission statement refers directly to our complex community and region and its constitution, and our institutional diversity statement refers to our status as a Hispanic serving institution, one of only 2 among the separately accredited academic health centers in the U.S., and again, referring to our setting and the needs of a socially and culturally diverse border population. So how did we do this? Well, the first step was bringing in the essential expertise. We made a commitment to, again, linking Spanish to our core values, and then bringing in professional instruction. So from 2009 to 2020, we partnered with the University of Texas at El Paso, their Department of Languages and Linguistics, to perform the instructors, to provide the instructors. And we had basic standards, which they were able to meet through their Spanish department. That was very important at the kind of starting point we were at. And in addition, we had the advantage of almost all of our instructors being native Spanish speakers with longstanding ties to the U.S.-Mexico border in El Paso. Now, recently, because of growth and in terms of the medical school size, class size, and the addition of the dental school and the costs related to scaling the contract with UTEP, we have pivoted to directly employed instructors. And I think that's one of those resource issues that each institution would have to confront. So we brought in the expertise, we made the investment. So space and logistical support were provided by the Paulo Foster School of Medicine Department of Medical Education, which I think is an important organizational feature of our school. Not all schools have a Department of Medical Education. Some have an Office of Medical Education or a department that essentially just borrows resources from the traditional medical school, basic science and clinical departments. But at the Paulo Foster School, we have a mission-based Department of Medical Education, which brings in all the disparate talent into its faculty to teach primarily years 1 and 2, the pre-clerkship phase of medical school, but then extend out to supplement didactics and supplemental aspects of the clerkship phase into years 3 and 4. The contract for instruction initially for us was $1,400 per student per year. And with class expansion, the total cost began to exceed $300,000 per year. And upon hitting that number, there was a lot of screaming and gnashing of teeth, at which point we, primarily led by the chair of the Department of Medical Education, pivoted to in-house instruction. With the hiring into the medical school of 3 to 4. We're still working on the exact number, but we have 3 funded spots for full-time Spanish instructors. And this has been driven by the things that I've already mentioned: growth and addition of new programs. And I think this was possible because there was minimal resistance, because we already had the established commitment and a clear argument for savings in terms of bringing this in-house. But it did require some schedule modifications. Unlike the UTEP contract model, where we would bring over a large number of Spanish instructors all at once to do sessions in small groups across the classes 2 days a week, the first year class and the second year class on different days, 2 days a week. Now we have a small cadre of instructors, and they have to provide instruction throughout the day on which Spanish occurs, according to that experiential learning cycle that I've talked to you about. So the other aspect of this was making it count, setting expectations. So we had a placement process for tiering our students in medical Spanish instruction that was based in the literature. So a very formal process of a pre-matriculation questionnaire, interview by an instructor at matriculation, and then shifting due to early performance in the Spanish instruction small groups. We basically had 3 levels: novice, intermediate, and advanced, but each of those levels was broken up into kind of a early and advanced group within that category. Attendance is required. And it's a longitudinal component of a required 4-credit course, that society, community, and individual course that you saw on the earlier curricular schematics. And just talking about future steps, we're looking very hard at just splitting out the Spanish curriculum entirely and making it its own separate freestanding credit-bearing required course, so that it's actually on the transcript that these students have attained a certain level of exposure and experience in medical Spanish. And again, it counts through an assessment program that's outlined, as you can see in this slide. So the other thing that we do, because this is a requirement, but it's not a traditional expectation across the nation in medical education, and we need to keep our students on task with why this is so important. We push hard on why this relates to our setting and our mission, and we always try to keep it real and motivating by keeping the content engaging and relevant to their medical training. So all Spanish instruction is provided in small groups using a form of instruction called task-based instruction, not heavily scripted. It is the medical Spanish is in this small group task-based instruction format as we get into the physiological system-based medical school units that I talked about, or traditional medical curriculum units that I talked about earlier. But all of that is preceded for the students at matriculation by something that we call immersion. And I'm reluctant to use the term immersion in this context because if I'm talking to many of you who may be language instructors, this is not immersive Spanish instruction. This is immersion of our new students who largely, because of the demographics of the applicant pool for medical school, come from the eastern half of Texas. It is immersion in El Paso. It is immersion in our local culture. It is immersion in their new medical school and their new colleagues. But it includes a heavy dose of conversational Spanish every day for the first 3 to 4 weeks of medical school, approximately 4 hours a day. And then, as I've alluded to already, as they finish that immersion period of their matriculation into medical school, they transition into the regular curriculum that proceeds for the next 2 years, in which they get 1 hour a week linked to the clinical presentation that provides the framework for each week's integrated instruction, and that is tied to their medical skills course. So this is just a little internal data about the feedback we get from students. This is from year 2, so the students have already had a year of this, and they're into their central nervous system unit, and this is pretty representative of the type of feedback we get. So I guess I put this in just to demonstrate that we get pretty good acceptance and high levels of satisfaction with our Spanish instruction. The students don't tend to push back about it. They can see the reasoning, both because of the setting and because of the clinical presentation curriculum and the obvious communication problems that a clinical presentation poses to a early stage medical learner. Let's see. And then looking at national data. So this is national responses to what's called the graduation questionnaire that all graduating medical students in MD programs across the United States participate in. At least their schools participate in it, and respondent rates are generally high. We are way above the 90th percentile in terms of students expressing that they had the opportunity to learn another language in order to improve communication with their patients. So I think there's some early evidence of success. If you compare this to the literature on medical Spanish instruction in medical schools across the United States. And the framework that's developing around this literature about what should be the criteria for or basic standards for medical school Spanish instruction, we meet all of these criteria: formal curriculum, professional instructors, formal assessment, formal course credit. And yet you can look at the numbers across the nation and realize that it's still, we're still in kind of an emerging group of schools that do this. So what about the clerkship phase, the years 3 and 4 of medical school, when students are out in the hospitals and clinics? In our environment, there's near constant exposure and opportunities for practice, but there is no continuity of Spanish instruction into the clerkship phase, required or optional. We do have some optional potential in terms of electives that students may do in a self-directed way, but this is still a challenge, and I'll talk a little bit about that more in a moment. We've recently reincorporated the Canopy Medical Spanish platform, which is an online platform in medical Spanish developed out at Johns Hopkins, but supported by many schools now. In the past, we had this for several years as available to our 3rd and 4th year learners, but there was low participation, I think, because of the heavy burden of medical school. But we're bringing it back, and we're incorporating it into the pre-clerkship Spanish instruction that you've learned about in those first 2 years of school. And we're going to extend opportunities to include it out into years 3 and 4. And then there's this issue of scaling our in-house instructor resources, which may boost clerkship phase instruction and include the residents, which I think is an important piece. So where are our successes? Well, we have this novel curriculum. We were the first MD school to, how did that happen? MD school to accomplish this type of fully integrated clinical presentation-based curriculum. We have an increasingly diverse and region-centric class. We're taking students that had, on average, on admission, lower pre-admission scores and educational enrichment, and we're having licensing, exam passage, graduation, and match rates consistent with national norms. And most importantly, to the context of this meeting, since conferring our first diplomas in 2013, we've graduated over 600 medical doctors, all of whom have received 2 years of clinically contextualized Spanish language instruction built on each student's skill level at matriculation. Again, where are we headed? We're headed towards extension of formal 4-credit, 4-recognition medical Spanish development opportunities into the clerkship phase. We're looking at certification programs throughout our educational programs, and including extension into GME, but that's, I can guarantee you, it's difficult territory. And we're also looking at converting this costly and innovative investment into scholarship. And let's see, as far as what I can recommend in terms of developing similar initiatives in other programs, my anecdotal experience tells me that it's very important to tie it to your mission, and your leaders must understand the tie to the mission. And you've got to articulate a systematic and motivating approach to integrating medical Spanish instruction. So when I was in medical school, I'll use the example of medical skills. I had biochemistry class, cell biology class, physiology class, so a siloed discipline-specific course structure. And then once a week, we would go off and they would show us how to use a tongue depressor, or how to use the right end of the stethoscope, or how to hold a reflex hammer. And it was completely disconnected from everything else in the curriculum. Not particularly motivating, not particularly effective. I would say the same thing for an initiative like medical Spanish. Integrated curricula allow you to link the language instruction or the skills instruction or whatever you're trying to tie to your curriculum to a motivating framework based on the learner's professional aspirations. It's important to provide expert guided instruction, so there's an investment there. You have to be able to tie or tier instruction to the student's skill levels, or you're going to have pushback or dropout. And then I'm a big fan of the idea of curricula based on experiential learning cycles. I think it motivates all aspects of instruction, including Spanish language potentially. And of course, it has to count. So I'm going to try to get through these last 3 slides quickly. One thing I would say is we don't have much data to suggest that curricular models per se, the schools that beat their chest about their problem-based curriculum or their clinical presentation-based curriculum or their discipline-specific course structure, there's no evidence to suggest that any of that really makes any difference in terms of licensure readiness and pass rates. And all of that ties back to what kind of test performance abilities the students had coming into medical school. The biggest single predictor is their MCAT, which is discouraging to a lot of people. But your curricular model is important because it provides the framework that you can explain to your learners, that you can explain to your faculty, how you can tie your curriculum together, how you can link the subject matter across a variety of disciplines. And in the case that there's been a rapid movement in the United States, most schools now will talk about their longstanding or their transition to or their new and innovative integrated curriculum. And it's because these integrated curriculum allow us to provide a motivational experiential learning cycle and also to bring in novel content to a traditional medical education framework that really needs to be there. And here we're talking about things like medical Spanish, we're talking about social justice, we're talking about health system science, and it's a way of resisting curriculum bloat and tying our intentions to our curriculum. So I hope that was helpful. I hope it was a food for thought and discussion. And that's what we're doing with medical Spanish instruction. And I'll get up here and stop sharing my screen if I can figure out how. There we go. I can't hear you, Dr.
Can you hear me now?
Yeah, there we go.
Thank you so much for that amazing presentation and all the amazing things that you've done over these past years. It's awesome to see the evolution of that program and where it is now. But before we go to the questions and answers, I'd like to introduce our next guest speaker who is going to talk she's actually a graduate of your program, the Paul L. Foster School of Medicine. And so she can share with us her personal experience in the program. Dr. Nayana Thomas was born and raised in Dubai, United Arab Emirates, and moved to Houston, Texas at the age of 11. She attended high school in the rural town of Manville, Texas, and completed her bachelor's in science and biology at Houston Baptist University. And after earning her medical doctorate at the Foster School of Medicine in El Paso, she moved to New Mexico and is one of the new pediatric first-year residents at UNM in the Children's Hospital. She is a travel and food enthusiast who loves taking road trips with her family and is now a big sister to a 1-year-old boxer German Shepherd. So, Dr. Thomas, thank you so much for joining us today, even though I understand you are this morning post-call. Thank you for serving and taking care of all those crying children, and thank you for not sleeping in on your Saturday so that you could share with us some of your personal experiences being in the medical Spanish program during your 4 years in medical school. Can you share with us what you like the most about your program?
Of course. Good morning to all, and thank you, Dr. Farajon, for that introduction. I am honored and glad to be here this morning, and more glad to actually see even Dr. Brower after graduation. So like Dr. Parajon said, I'm Nyana Thomas. I'm one of the new pediatric interns here in Albuquerque. And I'm here to just share about my experience, especially going through the Spanish curriculum at Paulo Foster School of Medicine. So just a little disclaimer. This is my personal opinion about the program itself and what I've learned from the program. In short, if I were to describe my entire experience, I loved the Spanish curriculum at Foster School of Medicine. In fact, it was one of the most attracting features of the school that wanted me to apply to the school and wanted me to interview there and wanted me to join the school itself. I come from a very diverse background, like Dr. Parajon said. I'm from Dubai, but I'm born Indian in nationality. So coming to the US, I had to learn English and be proficient in it in order to succeed. And I know the difficulties language barriers have when it comes to trying to just communicate, trying to express yourself. And I knew going into medical school that this would be something that I would see in my future career as a provider, as a physician. And especially for little kids, that can be quite devastating when you cannot communicate with your patients and when you cannot communicate with your patient family as well. I came to El Paso knowing barely 4 words in Spanish, which include hola, gracias, ¿cómo estás, and bien. And to grow from those 4 phases to knowing more words in Spanish, to be able to do a H&P in Spanish without an interpreter is a huge, huge victory for me. Just a few highlights about the program that I found attractive, like I mentioned before. The program not only taught Spanish language, but also taught about the Hispanic culture, and very early on helped us to develop an appreciation for that culture around us. And I think the biggest way they did that was by hiring a faculty that knew the culture, that knew the population of not just El Paso, but also Juarez, knew the population of even Las Cruces, New Mexico, and would bring their knowledge and their tradition and their cultures towards us. Our Spanish teachers not only taught us how to conjugate verbs, but they also taught us about Hispanic food, Hispanic festivals, religion, clothing, herbal medicines that the population used, and much more than just trying to sit there and learn sentences. This in a way made me much more prepared to interact with my Spanish-speaking families and show my humility and my empathy in a medical setting, because I was more aware about their traditions and more aware about their values. Another thing that I loved about the program was the class itself was structured, like Dr. Brower said, to not just teach colloquial Spanish, but also medical Spanish. But the way it was structured, it never felt like a classroom assignment. It always felt like an interaction, a conversation. And that's what I loved. There was no big books that we pulled out and just kept doing pages of just activities or assignments. We were talking, we were listening, we were watching videos or telenovelas and trying to figure out what just happened in that scene in order to develop our skills and to keep practicing the Spanish that we were learning. It was all about efficiency rather than accuracy. And the way they did that was by dividing us into levels, different levels of Spanish, whether that be you did not know Spanish and you came in as a level 1, or you knew Spanish and you're a native speaker and you went into level 3. So that way we were able to not just, and it was with our own classmates itself. So we were never shy because we were just practicing initially, as I called it, bad Spanish with each other. But that developed through the years, and especially during the first 2 years of medical Spanish training. And the last point that I absolutely loved about the program, and this I think is the most important, is the program taught me my limitations and my Spanish fluency and my comprehension, but it also taught me to at least try and to try and be confident in the Spanish that I know. I'm very transparent with my patients, and they appreciate my effort in at least trying to decrease or, if possible, eliminate the barrier that I have between my Spanish-speaking patients or families and myself. I don't sigh when I have a Spanish speaking family walk into my continuity clinic. I think like Dr. Cordova de Ortega was mentioning, I don't ignore patient charts that say Spanish across the top, that places that label on that chart and on that patient, because I'm aware of my I guess my level of expertise in Spanish, and I'm able to still walk in, introduce myself in Spanish, make them aware about my fluency. I let them know early on, hey, my Spanish is at a certain level. If at any point you do not understand me, I'm always, or if I do not understand what you're saying, I'm always willing to bring in an interpreter and have a deeper conversation if needed. And that conversation initially, when we were learning about it, was very, very uncomfortable, because it's hard to tell patients like you don't speak Spanish, especially when you're still learning how to speak medical Spanish and conversational Spanish. But now that conversation happens very natural to me. And I don't shy away from trying to break that language and cultural barrier, and from trying to build a good rapport with my patient families itself. So I can confidently say I've gone from saying hola, like just walking into medical school, and within the immersion period, I was able to say, yo quiero 2 tacos de pescado. And then now going into patient rooms and saying, buenos días, soy Dr. Tomás, un residente de pediatría, which is, hi, I'm Dr. Thomas. I'm a pediatric resident, and just going on, building from there a HMP that I'm confident in at that time. And so this is a huge accomplishment for me as a medical provider, coming into this world, coming into this country where English is not my first language, it's actually my 4th language. And to add on Spanish as a tool is a huge, huge accomplishment for me. So that's kind of my basic experience at Foster School of Medicine, as well as how I've been using that currently as a first-year intern.
Thank you so much, Dr. Thomas. Thank you for your time, for telling us about your experiences and all the things you like. This is an amazing program. I would like at this point to open up the floor to questions. If there are any questions in the audience that they would like to ask either Dr. Brower or Dr. Thomas.
Dr. Parajon, this is Lawrence Roybal. And first of all, I want to thank everyone for being with us today on behalf of the Hispanic Heritage Month Planning Committee at the Health Sciences Center. I'm with Diversity, Equity, and Inclusion at the Health Sciences Center under our Vice Chancellor, Dr. Valerie Romero Leggett. And this is an especially important session like the last session. And with both sessions, it's truly fascinating that we've seen such a demographic shift, which leads to the urgency of this innovation that we've seen that Dr. Brower shared and that we heard in the testimony of Dr. Thomas. So I want to thank them both, as well as the previous panelist. And Dr. Brower, you made me think about a conversation recently that Dr. Valerie Romero Leggett was part of leading at the University of New Mexico about community education. And we heard from physicians across the state of New Mexico about sometimes the disconnection that takes place between the central hub and our spokes around the state of New Mexico. And I believe that your presentation reminded me that the emergence of these other schools of medicine, like your institution, have led to greater innovation and greater opportunities for partnerships. And I believe that this is an example, and Dr. Thomas is an example of how that has benefited not only herself, but all of our communities. And so I just want to thank you both for being part of our conversation today and for lending to this notion that we have to work more collaboratively, and we have to see these institutions as not competition, but as partners that will lead us all towards greater innovation and partnerships.
Thank you, Dr. Rogo. I have a question for Dr. Brower. Coming from Dr. Royball's comments, do you currently partner with other institutions regarding this new program, the curriculum, and would you consider a partnership with UNM if we explore that option?
Well, as far as Spanish language instruction is concerned, our affiliations have evolved, and that's what I was talking about in terms of what Dr. Thomas experienced was instruction under contract with instructors at the University of Texas, El Paso, and their linguistics and languages department. And scalability is a problem. Whenever you talk about anything in medical education that involves small group instruction, scalability is a challenge. And the way we've dealt with the scalability issue while preserving small group Spanish instruction as a required element throughout 2 years of medical school is by bringing in in-house instructors. Now, all three of our current in-house instructors were involved with the UTEP program and are all native Spanish speakers from the border regions. So we've retained that flavor. But what this also does is allow us, because we have these people full-time in-house as part of our education faculty, we can start having more regular Spanish labs for clerkship phase and residency trainees. And for that matter, faculty and staff, and potentially create other programs. But this is all about in-person, small group, fairly intimate work, and we're happy to share what we've done and to collaborate on developing programs. I think this is something we really want to do as part of our desire to get some scholarship and impact out of the program. I mean, it was a large mission-based investment, but it does come down to doing this on the ground in small groups. Now, Zoom and WebEx are changing that dynamic, but even in that situation, I think we all realize that there's a different dynamic on Zoom and WebEx than there is in a classroom where you can swap stories and share ideas, as Dr. Thomas talked about happened in her groups.
Excellent. Any other questions from the audience?
One question, Dr. Brower. This is Alfonso Del Monte. I'm one of the pediatricians here at UNM. Is there collaboration currently with your interpreter services in the hospital and this program, or are they pretty independent at this moment?
They're pretty independent. You know, we don't own our hospital. We partner with affiliated hospitals, the main one being UMC El Paso, but also other hospitals in town. And we have our own clinic system. There's really no interaction directly between the translation services, which are kind of contract services at the hospital and in the clinic, with our medical education program. You know, the interpretation services are contract and profit driven, frankly. And we have clinicians in the Department of Medical Education in that run the doctoring course or the medical skills course that interact with our Spanish instructors, but we feel that what we really need are trained educators, trained language educators who integrate with our clinical context.
We have another question here coming from the audience.
Yeah, so hi, my name is Veronica Plaza. And my question would be, you mentioned the human resources you have is the 3 faculty allocated to the program. Could you talk a little bit about the budget allocation?
I'm sorry, the budget?
Right.
Yes.
Yeah, so as I mentioned, we've allocated up to $300,000 for contract instruction. And that's in addition to the kind of in-kind budgetary or expenses related to space and classroom support and coordination, course coordination with this larger framework, the SCI course. So there was a very substantial investment. Now, actually pivoting to the in-house instruction, it's looking to be significantly less expensive, but we don't really, it's all covered under the Department of Medical Education budget. And as long as they can show that they're continuing to provide the course support, the curricular and classroom support, the cost of the instructors is far below what we were spending in the last few years for contract instruction. I can't really be more specific than that. You know, that said, there is a desire to expand Spanish instruction into the dental school and into years 3 and 4 of medical school, and also to provide some resources to support residency experiences or opportunities to learn medical Spanish. And so the budgeting for that suddenly becomes more complicated, right? It's across 2 schools and potentially GME. What I can say is we're going to have to go beyond 3 full-time Spanish instructors fairly soon, because right now we're just dealing with 1 year of dental school, but this is their first year, right? So they'll be growing out to a 4-year program. Now, Spanish right now for the dental school is mainly conversational Spanish and only in year 1, but their class size will also grow. So we're looking at probably gradually doubling the number of Spanish instructors we have within the foreseeable future, 5 to 10 years. That's what I would anticipate, but I can't give you more specific budget numbers. Happily, I'm not involved with that.
Question as well too.
Another question.
I'm not the community, but I was wondering about the interactions that, and maybe both you and Dr. Thomas can talk about your interactions with simulated patients, and what I believe you mentioned that some of the patients were Spanish speaking only. How did that go for the students? Now that you have to do it across a number of different colleges and a number of different types of patients, I think there'd be a lot of benefits, but probably additional barriers too. Could you just broadly talk about the experience, maybe Dr. Thomas, that you have, and maybe Dr. Brower, about what are the challenges to getting simulated patients that are Spanish speaking, and how you would evaluate in that context?
So in my experience, I had quite minimal exposure to standardized patients that spoke Spanish, or where we had like our medical skills course that kind of had one-on-one conversations with standardized patients. That was quite less when it came to Spanish speaking courses or Spanish speaking situations. However, on the other hand, how our program kind of stated that was, I think I had mentioned before, there are 3 levels of that were placed into based on our proficiency in Spanish. I was a level 1 when I started out, and I had the rest of the classmates that are native speakers went to level 3. How they kind of changed that was they would have level 3 Spanish speaker Spanish colleagues come out and do conversations with level 1s and level 2s. And this would be overseen by our Spanish instructors, where they would see how our conversation went. And how they did that was they would have level 3 play the role of a standardized patient. So they would come in, say, if the scheme for the day or the scheme for the week was cough, then we would have a patient who was a level 3 medical student just like me, but just in level 3 class, come and present themselves like, I am a patient, I'm your patient, I have cough. And it was my job as a level 1 a level 1 Spanish speaking student to try and figure out what was going on in that situation and try, of course, also practice my Spanish. So I would go in, introduce myself like it was a normal standardized patient setting, knock on the door, open the door, introduce myself, tell them like, this is my level of Spanish proficiency. And then kind of go, why did you come into the clinic? Just like I would in a standardized patient setting. So that's how we've been able to mitigate away from trying, in order to make sure that the medical skills portion of the class, of the course was not affected by, but be able to still practice like we would if it was a standardized patient.
Yeah, and I would just add on to that, those of you who are familiar with medical skills courses know of the expense involved with having a standardized patient program. And it's logistically extremely difficult for us to find standardized patients who also have a certain kind of standardized level of Spanish ability to conduct medical skills sessions as part of the medical skills course in Spanish. We're actually working on trying to build a few of these activities in years 1 and 2, but it's a real challenge. And so what Dr. Thomas discussed is exactly the strategy we're using, although we are very sensitive to the issue of putting the burden on the fluent Spanish speaker to provide instruction, just like we're sensitive because of the innate aspects of our environment of putting the burden of treating or translating in the clinical setting on our Spanish-speaking trainees. Happily, most of the students who are fluent Spanish speakers or native Spanish speakers are more than happy to do this, but it's not an obligation.
We have experience here at UNM in 2009 with pilot doing OSCEs with standardized patients in Spanish, and the outcome of that was that the students performed their clinical communication skills performed in Spanish was higher than what the same student performed in English. So it was within pilot, we have a short portfolio of OSCEs already developed here, but has not been institutionalized.
Thank you for the comment. Any other questions?
Dr. Brower, thank you so much for your presentation. This is JP Sanchez. I serve as the interim executive diversity officer at the School of Medicine. I also serve as an associate editor of Meded Portal. Many of you are probably familiar with Meded Portal. It's one of the 2 journals of the Association of American Medical Colleges. Now, there is an opportunity to publish medical Spanish content onto Meded Portal. There is a growing set of publications that people can utilize with extensive facilitator guides. And I'm hoping that we could continue to have conversation because I think we can move potentially material that you've created, we're creating here and fulfill that additional objective of scholarship, publishing this content, including OSCE-based modules. There is a template in Meded Portal for OSCE, which would help eventually reduce the cost of the cost associated with running OSCE. So I'm hoping that we could continue to have conversations and do that. We actually also, to that point, LMSA, the Latino Medical Student Association, now has a National Center for LMSA Leadership and Advancement that has a fellowship program where the fellows are working to publish medical Spanish modules in Meded Portal, which would serve as another opportunity of support for fellows who want to publish this material.
Thank you. I think that's really interesting. You know, we've actually been struggling with this scholarship piece partly because of the contracted relationship with UTEP in terms of the Spanish instruction expertise and their engagement in the idea of scholarship with the medical school, and then also with changes in leadership in the in our SCI course, within which Spanish is embedded. And so we're to my, I mean, this is just a personal comment. I think the school and the institution has put a lot of systematic thought into incorporating Spanish instruction in a way that's motivating to students and very positive. But we haven't taken any credit for it in terms of scholarship or dissemination, and we're working on that. It's been a challenge.
Everyone, no other questions? Then looking at the time, it's already noon. We've gone over some, but this has been an amazing conversation. Thank you, Dr. Brower, and also Dr. Thomas. Your words and your experiences have been truly inspiring to us. We've learned that it can be done. We hope to continue the conversation about exploring ways that we can collaborate. And we're so happy to have Dr. Thomas with us here at UNM. And we'll be talking some more. I'd like to remind you all that after the lunch break, which was intended to be until 12:30, we will be back with a concurrence sessions. And if you go to the chat, you'll see that there are two different links. Concordance session A has one Zoom link and B has another. So be sure to click on the right one. But again, Dr. Thomas and Dr. Brower, thank you so much. And I hope that you have a great day.
Thank you.
Thank you.
So, also, if I could just say, we're going to stay on schedule. We'll only have 30 minutes for lunch. Okay. But if let's just continue to have discussion. We want to keep the community together. So as we get our lunch, feel free to pose questions via the Zoom link, and we'll have you a part of the discussion here. So I hope everyone can stay with us for the next two concurrent sessions. Thanks.
So there's Mediterranean sandwiches, veggie, turkey, tuna, and a few salads. There's chips, chips and sherry that go down. The black tea is unsweetened. And then there's some lemonade and prickly pear tea. For the next session.
Dr. Plaza, I didn't recognize you.
Oh, no. So you know the kind
That's right. No, I'm always on the phone with this guy.
So when you I get to work with your mom. She is phenomenal. That's great. Your mom works so hard, as you know. She takes care of all this. Right now.
She's
you have an awesome mom.
I know.
Your mom is awesome.
I feel like Melissa's the first person I told her. It's funny, I would agree that somebody else.
You're right. You're right.
And then, was like,
across the street. Yeah. So we're attached.
I remember because you had to point out, I was like, I need to take care of, but
No, that's the only one. So we're gonna have to disconnect from that.
I guess I'm gonna be here so I can pull up my.
well, we weren't sure how many were getting.
That was,
I'll be a surgeon. She's at home, so she doesn't need a room specifically.
I don't think that was right.
Oh, okay.
It's a cactus. Somebody I know that, I don't think, I just surprised Jamie's already on there.
You're not saying no, because I intended to not love it.
And Travis wanted to. So she can send me.
Yeah, Viviana said she was signing from home. Correct.
I can see her on there. She's already saying, yeah.
So basically, whoever stays in this room is going to see your session, and if anybody wants to see the other session, then we'll just have to stay
So
up.
where do you want me to?
I think that's the best thing.
You know what, Elisa?
Where do you want me to put the PowerPoint?
Is it possible? Because Luna and Tara seem to get along. They get. Remember in the rain?
Yes.
Remember you have mentioned the rain? Yeah. They seem to get along. I'm sure. Oh my gosh. She needs to play because she bugs us so much. She just like wants to play the whole way. Yeah, I was like that. A little calmer.
I'm always,
Yeah, I make pumpkin, I'm like, you.
getting creative to meet her community's needs is,
And back, and then I'm like, you're towards.
but it doesn't necessarily mean that it shouldn't be just done without the insertion of a level of excellence.
Yeah.
You know what I'm saying?
I have doctors who want to practice Spanish from perfectly fine. I know a lot of people don't, so I have doctors that are trying to I have interpreters who use you.
Yeah.
You have to.
So they get stuff, they just look at me and I tell the patient, se van a comunicar, si usted tiene que buscar una palabra o el doctor con toda confianza, no me voltean a ver y yo se las doy. So I have to just keep listening, and as they go, they'll look and go, oh, this, oh, that, or this, I use this patient, one of these.
Kindergarten. Yeah, so her
Our
kindergarten.
director doesn't like to study that, but I also know that that's the only way you're gonna get some practice on confidence.
It's Corellis International?
Yeah, you all were talking about.
It is not actually.
There's no problem with anybody learning.
It's almost
Alameda, and I only worry sometimes is that cultural piece is missing. And the fact that.
Yeah, so she learns only in Spanish, so she's learning letras.
I had doctors literally tell me.
En español.
Mira profundo, the patient is sensitive,
Yeah, I just wish, I don't speak Spanish.
Yeah.
At all, I mean, I know enough, a little bit, but it's hard,
We have people that come in and they say,
yeah, but actually, he went to
And
the
then
same
if I said, oh, my
school, so
God,
as he got older, it was a little harder to say, oh, well, limited with interpreters. We're not limited by more advanced,
You're
yeah.
limited by the communication, right?
El nivel, es que no es solamente el español es profesional y el español coloquial, y el español coloquial hay veces que hay que hacer la traducción a tres diferentes niveles, la interpretación a tres diferentes niveles, o sea, adaptarse al nivel del literacy del paciente.
And when I was an interpreter, I was next to the doctor said, let's wait out this door. And then that's where we go. The interpreter did a little translation, which would still be fine considering that's what you're doing. Well, you're not, we don't, I mean, if we've been doing this for a while, we know it's context, we know it's not. So dijo el intérprete, esperamos que pase la tormenta, which makes it sound worse.
Yeah.
So I was like, no, espérame, because then they go, todavía cantar la tormenta, like it was third grade. And I was like, no, we're not saying that, we're saying, deja pasar esta etapa y a ver lo que sigue.
Yeah.
So you're vamos a esperar cómo evoluciona.
Sí, a ver, como fue, como lo quiere decir, ¿verdad? Pero el caso es, no es, vamos a esperar la tormenta.
Yeah.
Vamos a esperar que pase la tormenta. Y entonces, ahí está, todo va a pasar. Yo, it's finding all those little things, it's understanding that, but I'm not limited in what I can interpret as far as, my provider's doing it great, but I always have to listen for that context. And even if I don't understand it, I go, hey, voy a pedir clarificación, I'm always transparent. I'm like, I'm sorry, doctor, you mean what?
Yeah. Balloons and jazz.
And then sometimes we just for the students. A good example was
So you'll hear the video.
a patient came in with an active heart attack. She started to had some aspirin. And the doctor said, so do you want to go to cath lab or do you want to let the heart attack run? Or do you want to run its course? Or do you want to run? No, what our friend is, that's exactly what he said. He said, paciente, no, pues que por el gusto. And so I kept looking at him and I go, no, what's running its course? Yeah, so. And then the doctor was like, I'm checking the patient said, el medicamento. And I to the school. What's running its course? And they were like, the heart attack was like, for so like the patient. And me acaban de poner en person around the pastillas. Estamos esperando el efecto de la medicina que cubre el curso de la medicina. And so I repeated it, doctor goes, no, I'm saying let the heart attack run its course or but it was that little thing and but it was taken us right. Let it run its course, no heart attack. Right. Because it was a very sad language. Yeah. So if you have an English teacher,
I just want to read them.
would they know that too, or would they know the difference?
I tell my I ask them, especially the monolingual speakers, are you bilingual? They say, of course not. I'm like, no, you actually are. You speak medical English and English.
Yes.
And there's a disconnect. And they do a lot of code switching without realizing it. We're going to watch this clinic. What does that mean to colloquial English, right? So they have to recognize that.
Pero es como que tiene 4 años de diferencia. Como que tú sabes que era el ellos de sangre. Ellos con sangre le van a tomar sangre y uno se análisis y el otro se cultiva, se tienen que esperar días a ver si crece una bacteria para darle un tratamiento. Si alguien dice, le van a hacer un cultivo, vamos a ver. Yeah,
for acute, you're having an acute change.
And
do you know how I can do this? Sorry. How I can do
I have a whole big top, a stock pot like this. Amazing physicians, and I'm afraid to log out. We just start having to figure it out. Doesn't usually we should have done is we should have okay, good. What we should have done is we should have had everybody's downloaded on the desktop beforehand.
We're still on that, isn't it? Yes, Jennifer was still on there.
So the session this morning went well. There's been
Never know what you're expecting.
I'm very confident that there's one wire that has someone.
And then I could also actually say
For me, this is all being like self-esteem. Absolutely.
Oh, say that. This is the data. 2 hours, please. It's such good. I didn't know that.
Sorry, let me see which room you're in. There's a split, right? So we should figure the four.
In español, right? Not in English. The other day I said, on Thursday, I said, oh, the letter E like elephant. And she's like, no. In español. E like iguana. Yeah, it's a great little school.
I think that's fine.
You need those into the contract.
I don't know why you wouldn't be able to.
I'm just saying, it's just my laptop.
They're not gonna be able to see your screen.
Sure. Yeah, sure. And let me see who's in what room.
Right, so the people on Zoom won't be able to see the screen. Oh, no, that's not true. You can turn it on, yeah.
Hello.
Yeah, as long as you're logged on.
How are you?
I was actually.
So I haven't touched base national baccalaureate school.
So we have, I just like, we started on really just talking about the plan. But if you use those slides, we're gonna
Which is.
If we kept a couple of them that would.
So they.
Not tricky ones that they focus on. How related.
You just want, like an overview. What are the 16 places?
I want you all to summarize, you know, how many people have done explored, who needs to recertify
Citizenship.
demographically.
I don't think I'm
You have it all.
Yeah, so everything that you teach is in that context. And so they take your subjects from that context,
And then
but
this will be.
the chosen language is school is Spanish. So this one's
So you can the second or third week.
So her pilot is approval, 90%.
This month.
And the other 10% is now just trying to get them like to understand the content. So it's like there's like 10 for 10. And then third grade goes and then 56 is at 50/50. And so like they tell you when you go to school.
As opposed to do it once a year.
You recognize
So,
Spanish.
do you have a?
No, it's all,
Might not
it's all
be
certain.
at
So it's
grade
the-
level
Wow.
until about fourth grade. Because it's not until that grade is the language. And so they warn you, like, you're just gonna go out and standardize exams in English, but before we could teach them in Spanish. So she's not learning how to read in English, she's not learning English letters, nothing, it's all. It's a charter school here in town that they go to. Well, my son goes to a school. What school is it? It's the same IB curriculum. Yeah. In Spanish, yeah. Is it on Lenore? Montgomery.
You guys are opportunity.
Corrales.
This is you.
It's a great program.
Yeah.
He finished, we haven't.
I was mostly thinking about this Zoom link, but that's the same Zoom link from the morning, right?
Well, he is, but I think like their sixth grade, they kind of cut out as much Spanish, and so he's lost a little bit, but he can read it and write it better than me. It's hard because they have a hard time finding teachers. And so, yeah, like, it's really tough. The kindergarten teacher has been there since he was there, so definitely, more than 6 years. And she does not speak, she does speak English, but not well, right? So she teaches Spanish completely. And then he had, I don't remember your first and second grade teacher, but it wasn't until teacher that he had a.
You can log in?
No, I wonder what you signed in with the different accounts.
That's what's happening with why I'm getting here. So.
They supplemented by all the Spanish.
No, they didn't sign in.
So
We have to log out.
Every year, it depends what teacher they really have.
So that'll kill them. Like I cannot sign, it does not give me a choice other than the HISLIC instructor.
Okay. We'll just have to log on back to you.
And then they just.
So yeah, I can switch.
They have what they almost.
Yeah.
You know,
Well, now you sign as a different person.
maybe.
Okay, so thank you. Yeah, buenas tardes. So I'm gonna talk a little bit about medical Spanish in pre-health and our experience as a primary prevention approach to develop a workforce and that will be bilingual and our experience here at UNM. So why medical Spanish in a college pre-health education? So we have here from the previous speakers that is a large growing vulnerable population in the U.S. And also because the UNM is a Hispanic service institution, we have 22,000 students enrolled. From one of those now, that number is increasing, is 18, the latest number for this year. And among that, 50% are Hispanic, have a Hispanic background. So, is that? So, and also because when we look at health data, we can also always see that among almost every illnesses, there is a disparities and how it's affected the Hispanic population. So if we just look at, the COVID as an example, you can see how our Hispanic population was higher impact when the pandemic was started, and we started with doing case investigation at the Department of Health. It was also the challenge of not having enough bilingual healthcare providers to do case investigation or contact tracing. At the time, like early May last year, we were only few of us to deal with that at the whole state. Was only 20 of us, and all the scripts were not developed bilingual. So that's such an example of, how is the need, and that translates also what happened in the hospitals, but also translate in mortality. And that is on the whole spectrum. In terms of incidence and prevalence, we have, there is a disparities in how it's affecting the Latino population. As a nation, we have a part of our Healthy People 2030. One of the goals is to improve health communication. And so our approach to improve health communications also address the language. When we look at what are the needs for, or what are the things that are we looking for people coming into medicine, they have to have not only having to be service-oriented, social skills, they need to have cultural competency, they have to learn how to work in team, but they need to have the skills to do oral communication. And in that is also being able to communicate with the people that they serve. When we look at the issues related to patient safety, quality, or cost, the language, the patients that have limited English proficiency have their health outcomes are being affected. And I'd like to mention here one thing in terms of the ELP definition. What you can look at ELP definition is English language, so that we can look at from a deficit from the patient that only have a limited English proficiency, or we can look at us from the provider's perspective that they have only English proficiency and they have limited to English provider. And if we look at that and change it from the patient to the provider, then we have to address the issue of how we develop providers that they have more than English as proficiency. So there's also the issue of adverse events and how we can prevent that. And that's how adverse those are caused by the language issues and how that can lead into harm experience or adverse events among the English speaking. And when we compare that, we can see that there is a difference between those patients that are limited English proficiency and the main language that is speaking in the country. So how we can prevent that is part of doing what we call risk management, how we can improve and how we can create that so that we can prevent those adverse events. But it's also had to do with how we be in compliance with the laws and regulations that we have to function under. So in terms of the laws, we have Title VI that was passed in the country in 1964 that has said that it cannot be discrimination based on language, national origin. There is the Rehabilitation Act. There is also the Health Burden Act. That is the law that any healthcare organization that receives federal funding, they cannot discriminate versus based on language. There is also the latest law is the Affordable Care Act that in Section 542 state that healthcare organizations have to not only report health outcomes based on race and ethnicity, but also based on language preferences. And then in New Mexico, we have the New Mexico Hispanic Education Act that states Hispanic have the right to receive bilingual education. So in terms of implementation of these laws are monitored through the Office of Minority Health under the class standard. And the class standards basically they've been in place and has been reassigned. And then is that have the main one is that there needs to be provide cultural, linguistic, appropriate services that are effective, equitable, understandable, respectful, and quality care and services that respond to the diverse cultural belief, practice, and preferred language, and help reach the level of the population that they're being served. So we know that nationwide, not all the medical schools are providing training. So that's why it's important to provide a training as a pre-health before they get into medical school, and that's why we call it a primary prevention approach. So we also know that in terms of laws and regulations, accreditation for healthcare organizations through SHACO also demand that they have to meet the requirements for clinical communication competencies, and that's part of the training for all the levels of the workforce, not just for medical providers. So we did an assessment here at UNM back in early 2014, and we in the study we look at 132 medical students. We did an assessment on terms of their language proficiency versus their self-assessment versus the assessment with BERSAT, and then we find that basically there was the formal assessment kind of correlate with their self-assessment. However, when we ask them in terms of their skills of non-clinical communication versus straightforward clinical versus complex versus legal, their level of competency was decreasing as the complexity of the conversation increased. So we took a primary prevention approach, and since 2008, we developed a bilingual, try to develop a program to build a bilingual work health force for New Mexico. We have done many initiatives on both sides of the campus. On this timeline that Dr. Valerie Romero presented earlier, we have on main campus the funding through the federal funding through the Latin American Institute with Title VI that help us to pilot, and then the institution was able to institutionalize the program in 2013. On the North Campus, we have a series of pilots from PIN as an elective to the summer practical immersion, where students were allocated in during the summer in around the state with 2 weeks of medical Spanish training, and then work into sites that have a Spanish-speaking population with a final evaluation of OSCE at the end. Then we have, student then was moved into interprofessional education. Then we have some students-led initiatives during lunchtime through CASA. And then we have a series of the clinical communication skills trainings on how to work with medical interpreters. In 2019, the ED allocates some time for residency training, protected time to do medical Spanish with Dr. Linda Villamart, and then in family and community medicine, they also have allocated time for training with residency school. And in also 2020, we did an online training system-wide on health science that will be presented next. Now, in terms of the overarching goal for the pre-health students, the idea is that create a pipeline efforts to increase that will increase the healthcare providers that are bilingual, and also improve the quality of health encounters for the Spanish-speaking population in New Mexico. As we develop the curriculum plan, we have a plan that was they started with a placement test, and the students can come in according to the level of proficiency at 100, 200, or 300 level, and that's how to go with no knowledge to conversational knowledge. And based on that, they can progress through the 4 years of college, ending up most of them taking the programs through the Office of Diversity that will help them to get into graduate school. So the plan is based on, the fixed foundational knowledge, so that they have to do with, they have the intrinsic motivation or a motivation to apply that knowledge and have integration and have the human dimensions, and then they have opportunities to apply that into a service learning experience. So we were able to develop from one course to develop a minor and a second major in Spanish. Students can have how to meet at 12 credit hours of training, and then have an option to elect from 6 credit hours from the other portfolio of courses that go from traditional medicine, medical Spanish and public health, Hispanic literature and health and healing, bioethics and integrated medicine, más vale prevenir que curar, and then narratives in medicine, and a course on practice of medical interpretation that that prepare them to take the exam to become a certified medical interpreter, a CCHI. The second major have less credit hours, so they have more, so it's 12 credit hours, and they have to take 12 credit hours in terms of electives. So the courses go from a very second, 205 or 200 level course that they have, where they can develop skills in terms of reading and writing and speaking, basic level, to go to 300 level courses where we learn how to take do a clinical encounter, how to take a clinical history in the context of public health. And then the narratives in medicine is like through literature, and learn how to deconstruct the narratives and how the patients tell their stories. And then basically have the help on, we use a kind of the literature and standardize or simulation, kind of use a little simulation medical education in a classroom setting, where they do a lot of role plays in terms of playing patients and providers. Then we go into the bioethics, and we do that with film. And then they go interpretation, to do an interpretation practice. So those are like the core courses that students have to take over the 4 years in order to be able to take the exam. Then they can also do through literature. And in terms of the topics, they have the component for service learning. So in terms of service learning, our students have served through a partnership with Community Engagement Center. They have worked since 2014 as part of, we train them and as part of become Medicaid enrollers, and they work in partnership with APS and at SHAC And then also the students volunteer as a work studies at the clinics, the local clinics that they serve, mostly Spanish-speaking population underinsured at Casa de Salud, One Hope, and Simple Salud. And so when we look at our approach, as approach have meet the standard, the recommendations for standardized medical education in the US, because we have meet the 5 components in terms of knowledge of the systems and interview, medical Spanish knowledge regarding common disease, patient-centered explanations through the different clinical communications models, and then patient-centered exploration and negotiation of treatment, so through narrativas and medical Spanish and public health. And then we also do the part of the evaluation. The evaluations has been done using the AAMC TAC for cultural competency training. And then it's also through IDEA, that is the UNM evaluation system. So since 2009, we have trained more than 2,000 students that have gone through the program. And from one course, now we have a second major and a minor, and being able to institutionalize that on main campus and have all when I say pre-health, that include, students from nursing, speech therapy, pharmacy, pre-health, and also health education. So, and we have a map out that we have been serving our 33 counties in New Mexico. We have trained students from all our counties in the state. So where are we going from here? I think it's like we've been able to bring and institutionalize a program that prepares students to have a skill level before they get into graduate school. I think that we have what we have done on main campus now have kind of, we can build up and continue and kind of institutionalize into the graduate level, because the challenge that we have faced is not only the funding, but also the time allocation within the curriculum. So the integration of the curriculum within the existing program, I think, is the next steps that we can take.
Don't stop sharing. Go ahead, yeah. Go ahead. Stop.
Next, I'm going to have Professor Buck share with us her program and the obstacles she sees to becoming proficient in Spanish medical language as well. Thank you for joining us. Dr. Buck, thank you for your patience regarding the IT.
No, not at all. I am more than familiar with that. Thank you very much for having me. I'd love any opportunity for CNM and UNM to work together. So in fact, I was not familiar with the amazing medical Spanish curriculum that Dr. Plus has just outlined. Fantastic, really wonderful. We are newer at this. We just began our Spanish interpreter program at CNM. And I will tell you maybe if we have a few minutes, just how it came about. My mother actually was a medical interpreter. And earlier today in one of the talks, I heard that UNMH has over 100 Spanish interpreters, which is amazing. My mother was one of 3 in the Woodland Memorial Hospital, which was in the Central Valley of California. So she was dealing with migrant farm workers, and still they only had 3 interpreters. So it's excellent that we're really staffing our hospitals with interpreters now. So CNM, of course, as a Hispanic serving institution as well, we recognize the need to serve both our students and our community. It seems almost impossible that we hadn't had this before, but a colleague and I talked about it, and then we had this wonderful confluence of good luck, which rarely happens, which was we had funding and an excellent dean who was really into it. And so my colleague and I decided that we were going to create this at CNM, that it was past time for this to happen. And so what she and I ended up doing was actually enrolling in an interpreter program in Arizona over the summer of 2 years ago, which was the hardest thing I think either of us had ever done. One imagines that one is quite fluent, and then being put in a program like that really, really tests you. So it was wonderful to see from the students' perspective as well what was necessary in order to really to develop the kind of proficiency necessary for this very important work. So we came back, we spoke to our community stakeholders. We have a wonderful advisory board, and we started putting this together. And as we were putting it together, we had to be very cognizant of our demographic, which we have a lot of students who are bilingual, culturally bilingual, I might say, in that they understand but they cannot produce language, or they might have they don't have the specialized language that's necessary in order to be an interpreter. So let me see can I share my screen here? I think I can. I wanted to show you what our program looked like. We just started it in the spring of 2020, and then COVID hit, and it was an adventure. What we've done is, because we have mostly a full-time worker demographic, those are our students, we had to put this together in a way that didn't take too long, but still addressed all of the competencies that we were expecting from them. And so what we do is we have 2 classes per semester. It's a hybrid format, so at least that's what we had envisioned, where they would meet for one class, and then the second class would be online. And the students go in with sort of a general interpreting, and then they can choose whether they would like to go the legal route or the medical route. And this is what our curriculum looks like. So they have the fundamentals of interpreting, and then in the second semester they take either the medical or the legal, and then they're learning the simultaneous interpretation, which doesn't happen as much, I think, in the medical arena, but it does in the legal, and then consecutive interpretation, and all the way down, and that's 5 semesters. So it's still a bit long for a 2-year college, but we are in our second cohort now. Our first cohort graduated earlier this year. And in fact, I think we have one of our graduates has since been hired by UNMH. So that's very exciting. The things that we still find challenging, and this is changing as we go, of course, because as we see what things are required, as we see what is working and what isn't, we are changing things. But we do run across the problem of proficiency for the students who are coming in. because it's as we know, a very different thing to speak Spanish as to be able to really have that sort of specialized language, and also to be able to go back and forth between the languages, and that balance is difficult. So we do sometimes, if we have a student who needs to sort of bump up their Spanish, we'll put them in a heritage Spanish class. We have sort of a Spanish boot camp that we're trying to provide for them, and our placement test is really what we rely on. We require a placement test at the beginning, and then they speak with one of the faculty members, and we sort of assess their proficiency. And we'd love to be able to insert some of this. At least we do offer just a Spanish for medical professionals class, but it isn't required, and it's not really inserted into our nursing program or to any of our health courses. And I'd really love to see that kind of joining of the fields that way. But we're in our second cohort, and we're hopeful, and we've really appreciated the insight from our colleagues at UNMH in this. So.
Again, I'm Cameron Cromwell. I'm one of the faculty members in emergency medicine, and I also work in the Office for Diversity. I'm here with Jaylee Caruso, who's one of our medical students who's really done a lot of work in raising competency and capacity in the School of Medicine. What we want to do is show you the results of a pilot effort that we started back, gosh, I don't know when we really started, but we really, over a year ago, we rolled out an online curriculum through a product called Canopy. And what we want to show you is the results of this effort, and to talk about maybe some potential next steps. There's a number of people. Do want to recognize everybody, a number of individuals from the Office from Diversity, like Dr. Romero Leggett and Dr. Sanchez and myself. And then also Dr. Paso was very involved, Dr. Aragon from Family and Community Medicine, and Jaylee Caruso participated heavily in this project. So I think Jaylee's going to give us some background, and then we'll go into the study itself.
So I'll just start by giving a bit of background about our study and its importance to New Mexico. Here in New Mexico, we serve the largest proportion of Hispanic or Latinx identifying individuals of any state at nearly 50% of our population, with over a quarter of our residents over the age of 5 speaking Spanish at home. And as we've all witnessed, language barriers really serve as a major obstacle for Spanish-speaking patients when they interact with the healthcare system. And as discussed earlier today, it's been shown that language concordance between patients and their medical providers really does improve patient outcomes and satisfaction. And Dr. Plaza went into this a little bit as well, but the CLAS national standards is really a way to ensure that patients have access and legal rights to both cultural and linguistic competent care. And this slide has been talked about in depth throughout the day, but it kind of just shows the progression of our efforts at UNM, both on Main and North Campus, to improve access to medical Spanish for our learners. So as part of our study last fall, we conducted an inventory to assess the existing medical Spanish opportunities at the HSC. And to do this, we reached out to 14 different groups associated with the HSC campus. And what we found was that only 6 of the 14 groups provided some sort of medical Spanish learning resources to the campus. And primarily that consisted of electives, online classes, or in-person instruction on main campus. And so you can see in this table, this kind of lays out the departments that do provide medical Spanish opportunities to HSC. And one thing we noticed is that These opportunities are excluded mostly to health professional students enrolled at HSC instead of being offered, to HSC-wide staff, employees, and other learners. And so along with this inventory, we also offered a pilot program to this online medical Spanish platform, Canopy 2.0. So this is a 40-hour online self-paced curriculum. It consists of 3 different levels of Spanish language learning, reviewing content such as Spanish grammar, vocabulary, and then also delving into topics related to clinical medicine. Each level is building in difficulty and kind of goes upon lessons that were taught earlier in the curriculum. As part of this program, there's a pre-assessment that participants will complete before that they start taking the activities of the curriculum, and this sort of stratifies their Spanish language levels so that there's some sort of like baseline to see where you're at with your Spanish skills. So Dr. Crandall's going to go a little bit into the data.
So we want to share the results of the pilot programs that we offered through Canopy. We just want to give you initially a brief overview of sort of where the data come from and get an idea of the participants. So we offered the course through HSC Connects and other email offerings. Individuals who were interested in that then signed up on a smart sheet. We had 1,450 unique people at the HSC who expressed interest in the program. We then sent those individuals a baseline evaluation to find out their where they worked, what their baseline assessment, their own self-assessment of their skills, and what they were essentially looking for in a training program. Once they completed this baseline assessment, we had 1,253 people do that. We would then provided them with an online or the information about how to get a Canopy Learn account. And Canopy is a private vendor that offers this medical Spanish, and it was offered free of charge. Normally, their training is associated with a cost. So we had just shy of 1,000 people then actually obtained a Canopy account. So only 75% of those individuals who went through the baseline assessment got an account. Then we had, once you signed up for an account, you had 90 days to work through the program. And at the end of that period, then we did a follow-up assessment to kind of get a sense about what people felt were the strengths and weaknesses of the program. And then they also did another self-assessment of their proficiency. So first of all, who participated? We had a large number of individuals, again, participate, but most of them came from the UNM hospitals, with over 700 individuals from the hospital, representing a little bit over half of the entire group. The next largest group was the School of Medicine, but we did have participants across all of the entities in the HSC. When we looked at it from a point of view of what their role was in the institution, staff were the largest group, and that was mostly from UNM hospitals. Unfortunately, I don't know whether or not they were frontline staff or nurses. We didn't ask that level of detail. But we had every group represented, including students, staff, and faculty, in addition to the hospital staff. In terms of their baseline Spanish language experience, nearly all, 84% of the participants, said that they had had some general Spanish language training, and only 16% said they essentially had none. But when we asked individuals about their medical Spanish, and that was the pie chart on the right, really only about a third said that they had had some. So the vast majority, 61%, said they had had no medical Spanish training. Looking at the Canopy utilization, 945 people created an account, but only 615 of that group actually completed the pre-assessment that helped an individual gauge what their level was. Their average score was 42.5 out of 100. On the chart on the right, we looked at how individuals progressed through Canopy. So level 1 is the lower level. And so only 175 people accessed at least one lesson and 59 completed all of them. And then the numbers continue to drop down. So ultimately only 8 individuals out of the original group completed all of the lessons through levels 1, 2, and 3. We did see, despite the low engagement, we did see some improvement in self-reported proficiency. On the left is the baseline proficiency score. Most individuals felt that they were not at all proficient in medical Spanish, with 88 saying that they were none or low, with the median level being none at all. In the follow-up assessment, though, we did see a significant shift towards, again, mostly from not at all proficient to low proficiency. So really a very modest improvement in self-reported proficiency. You want to talk about this one? Or? I'm going to do the barriers and I'll let Jilly finish up on the rest here. We did have a number of technical challenges with this. Number one, Canopy needed a modern browser, and since most of our participants came from the hospital, and the hospital defaults to a very old version of Internet Explorer, I know that Dr. Plaza and I spent a lot of time telling people how to actually get an account and getting everything reset. So you have to have a system that's going to work for this to actually to move forward. It took multiple steps. Because of the health system, they did not want us to send out email directly to everybody. We had to do it through this advertising process. So we had the, again, unnecessary, it felt like barriers to get people on board. Ultimately, only 47% of people reported getting a Canopy account actually even did training. So there's a number of barriers. When we asked them what their challenges were, most said they simply didn't have enough time to do the training. And ultimately, their engagement was low as well. Only 91% of the respondents in the follow-up survey said that they spent no more than 2 hours per week on the training.
All right. So despite these challenges and barriers, there still remains a high desire at HSC for individuals to improve their medical Spanish. When surveyed at the completion of this study, 94% of respondents reported being at least interested or very interested in improving their medical Spanish by taking some sort of class or education. And nearly all participants felt that it was important or very important for the UNMHSC to offer medical Spanish opportunities for learners. When asked about what types of learning activities they prefer, most often people preferred having some sort of medical Spanish training, but there was also still a lot of interest in general Spanish education for HSC members. And then a good majority of people were interested in either continuing using Canopy to improve their medical Spanish or having access to some or other online training. And a lower percent were interested in taking in-person instruction at 38%. So in summary, we found that despite the high number of Spanish-speaking patients that HSC serves, we really have a lot of limited resources for HSC members to improve their medical Spanish. And while there is a very high, notably high interest in medical Spanish on campus, we found that in this study that there was still pretty low retention and completion rates of our online curriculum. We want to stress that our study did not assess proficiency. So the completion of Canopy in no way would replace any sort of formal language certification or the use of certified interpreters when working in a clinical environment. We still believe that Canopy remains a useful resource for learners, But in order to truly enhance language equity, a more comprehensive solution is needed. And I feel like that has been discussed a lot today. There's a lot of great and innovative ideas in our state and in partnering states, but things such as developing pipelines to employ more bilingual health staff is really important. Collaborating with exchange programs to increase access to bilingual education, and then also encouraging graduate programs to incorporate medical Spanish into their curriculum. All right. Thank you for your time.
Yeah. Let me, one last thing. Dr. McLaughlin, he apologized. He sent me a text. He was having technical issues, couldn't get on. I do want to talk briefly about just one other project that we're working on in the emergency department is to develop a program of medical scribes. In the past, we've used outside vendors to provide a scribe who assists the providers with their documentation. So it allows a doctor or nurse practitioner to basically interact with the patient and to really just talk and get a history, and the scribe will take down this history. We're trying to bring this process now in-house. We're going to train the scribes ourselves, and we think this is a great opportunity to kind of combine in medical Spanish skills with the scribe. So we're looking at developing a new pipeline program, essentially having a dual role position, having a scribe, but looking specifically to hire individuals who would be bilingual and who could do both of those roles. So I think that's one thing that we're very interested in doing. It's being supported by the hospital. So it's something that we're going to start in the emergency department, but we hope we'll then move forward into other areas.
Bio and relates to our complete care program. It was published in the American Heart Journal.
Well, thank you all for joining us today. Thank you all for your patience with the IT issues. I know it's very disorienting, but I think we pulled it together, and I hope we all get to continue tying resources and supporting each other in our endeavors to train medically Spanish proficient individuals. Thank you.
I know we need to move into our closing session, but I did want to make a quick comment. When we started off our conversation about trust and language barriers being one of the challenges that creates a challenge with building trust, I truly appreciate that this session emphasizes the idea of connecting with our community partners. And Dr. Plaza, you've been an inspiration and a bridge to various community organizations, such as Encuentro, el Centro de Igualdad y Derechos, Enlace Comunitario, Enlace New Mexico. You mentioned the Community Engagement Center as a partner, but I truly believe that our community colleges, as Dr. Buck described, and then of course these efforts that Dr. Crandall and Dr. Plaza described, are all avenues for building greater trust by building greater fluency in our educational environment through language accessibility and advancement. Thank you.
All right. Thank you all for joining.
So I believe this is the same Zoom address as the closing remarks. So we're just waiting for the other session to finish so that we can proceed with the next and final part of the program. And so I'm guessing our participant numbers should go up and not down when we're there. And we definitely obviously need our speaker. So I'm the moderator for the last session, so I'll wait until Eliana is on and the numbers look right and we'll get started.
Would it be okay if I asked a question to whoever is around and willing to take a second?
I would say yes, definitely. Go ahead.
Okay, I'm a physician assistant student, and I was sort of really interested in a lot of the, especially the SOM programs that they had mentioned, and I was wondering if any of those are open to PA students. I'm definitely fall into the camp of, being very conversationally fluent, but really interested in developing like my medical skills in particular. And so I'm just trying to figure out the best way to do that as I head into practice next year.
Yeah, and maybe someone can answer, but it sounds like the Canopy program would probably be good, but I'm not sure if that's open to everyone. I'm not sure if Dr. Crandall can still hear and would be able to answer that.
Hi, I'm not sure if Dr. Crandall and Jaylee are still on this, Dr. Romero Leggett. But with the Canopy session, we're no longer providing it as part of the institution. The time period for that ended a couple months ago, but you can certainly go online and you purchase it, right? Like you have to purchase, but you can do it in segments, so you don't have to do it all at once. And part of one of the solutions or one of the recommendations might be, is that something that we might be providing as an institution along with, all of the other things, right? Courses and sessions and the new initiatives that Dr. Crandall was describing in EM. So it may be one of the things that we can offer maybe as part of the comprehensive strategy. But currently, you could go online and do that yourself. I was trying to think if there was still, I'll have to check. There was a lunchtime group that was meeting with some of the faculty members and students and residents to practice both Spanish and medical Spanish. And I will look and get back to the group if that is still actually occurring. So I'll check on that as well. And I know that Dr. Plaza and the family medicine residency group that are meeting, I'm not sure who all could join, but we can I don't know if Dr. Plaza is still on, but we can sure ask and check with her on that, because that might be another, or Dr. Moraida, are you part of that group?
I am not.
Okay.
But I think the schedule is readily available on the Family Medicine Wiki.
Yeah.
And I'm sure they wouldn't mind having additional members to practice with.
Yes, I think that's a great idea, and it was a great question. Yeah, thank you for reminding us about that, Dr. Moraida, too. And maybe you could reach out and ask Dr. Plaza that question by email, or you can email me and we can get you the information for that. And Dr. Moraida, who is the other faculty member leading that? Can you remind me?
I'm not sure. It might be Dr. Kathy Chang.
Yes, thank you. That's who it is. So either Dr. Plaza or Dr. Chang, if you reach out to them. And again, if you're not sure, I'll put my email in the chat and you can reach out to me and then I'll connect you all.
Great, thank you so much. I really appreciate it.
Thank you, Diana. I'm going to put it right in the chat now. Thanks. There's Eliana.
Sorry, I didn't realize my name was not Eliana.
I did that the other day with John Leggett. That's who they thought was on.
Is the other session over?
Yes, it is.
So you think we can get started or? Probably. Okay, excellent. Okay, so hello everyone. My name is Selena Silva. I'm one of the doctors over here at UNM, and I am the moderator just for our closing remarks. So I actually get the opportunity to introduce Eliana Garcia, which is wonderful. I want to tell you just a little bit about her before she talks. She immigrated here from Colombia. She graduated high school from Carlsbad, New Mexico. She completed a Bachelor of Science in Psychology as well as a minor. And she's about to graduate from our BA MD program. Her BA is in biology. She also has another minor, and of course, she's going to have her medical degree. Eliana has always had a strong interest in giving back to the community, and her life experiences and training has created a desire for her to pursue work in international health for the underserved and culturally responsive care. She's visited 26 countries on her journey so far and holds a number of leadership positions, which include lead coordinator for the Native Health Initiative, Healers of Tomorrow. She helped coordinate the One Hope Women's Clinic as well as immigration clinics. She's also a board member of Forward New Mexico, and she's the Southwest Service Chair for the Latino Medical Student Association. More recently, she's a recipient of the prestigious Oliver Goldsmith MD Scholarship, which only about a dozen people in the country were awarded. Eliana plans to pursue a career in OB-GYN and will continue her work providing culturally responsive care for underserved communities. I want you all to remember this young woman's name, as we know she will do amazing things and she will make her family as well as UNM proud. I will now turn it over to the soon-to-be Dr. Eliana Garcia.
Oh my goodness. Thank you so much. That was beautiful. I really, truly appreciate that. And everything that you mentioned is everything that I do, it comes from the heart, and I'm super passionate about what I do and this event in particular. And on that note, I would just like to take a moment to simply take today in. We began the day with technical difficulties, yes, but we learned about the need of language concordant care in our state, in our nation even, and how interpreter services and the many resources that we as physicians use and our healthcare system uses, and how that's helping address the need. And we also talked about when we connect our minds and our minds, our nuestras mentes, and our hearts, nuestros corazones, to remember the true passion and meaning of what we aspire to do, how we aspire to serve. So hearing these incredible stories of physicians who spoke about how having the asset of speaking a second language, speaking Spanish, and being able to connect with your patients and help them in ways that is difficult to find and is difficult to do if your physician doesn't speak Spanish and can't connect with you on that level and can't build that trust. So just hearing those stories today was started out the day amazing and inspiring. Next, we explored an action plan of what is happening to implement programs such as the program at Texas Tech University that is already a leader in this initiative, as well as Kaiser Permanente Group, who is also leading this amazing initiative. And hopefully we can follow their path and continue to expand language concordant care. So this is an initiative that needs not only our hearts, but our brains to succeed. And the last thing that I think is needed in this big pool of success is our culture. As we celebrate Hispanic Heritage Month, and I see our institutions shining light on the strength of our culture, I feel proud to be a Colombian immigrant. It is a reminder that as an individual and as a trainee, I have so much to personally bring to the table. I bring not only diversity, but a gift of connection, a gift of leadership, a gift of culture. My fellow community, I hope that this Language Equity Summit reminds you that medicine needs us. We are the future of language equity, culturally responsive care, and compassion. This is what will get us to the brightest future that we deserve and we need. With this, I would like to close with a moment of gratitude and a story. I invite you all to close your eyes and travel back in time. So everybody's eyes closed, and for a moment, think about
your childhood, a moment of your childhood where you were happy to be a part of a tradition in your culture. This could be getting together with family to do novenas, celebrating Dia de los Muertos, or simply just Sunday dinners with your abuela. I don't know about you, so you can keep thinking of this moment, keep it in your heart, keep your eyes closed. I don't know about you, but I personally think of my abuela when I think of my culture and my family and the love in my heart. And I just remember how amazing the Colombian food she makes is. So when I think of these dinners at her house, not only does my mouth start to water, but my stomach and my heart feel very warm and happy inside. So I want you to focus on how this moment you're remembering right now makes you feel. Okay, you can open your eyes now. So hopefully that feeling of a mouth or a watering mouth or a warm heart and stomach, hopefully you can apply this to why our culture is so special. The moment that you traveled in time for is ironically the very reason why this current moment is so important. The innovation of medicine towards language concordant care and culturally responsive care has the ability to provide a quality of medicine and healthcare that will be tenfold to how it is today. Hopefully leading to healthier, more vibrant Latino, Hispanic communities and more of the happy family dinners with our abuelas. More moments like these, or like the ones in your hearts, are what is important and are what we are working towards. I'm so thankful and happy to be part of this generation and this movement, and I hope to continue to unite for language equity. Thank you so much. Only announcements that I have is that we ask that you mark your calendars and lend support for our 10th annual LMSA Southwest Regional Conference. The theme is El Tiempo de Cambiar, the importance of diversity in medicine. Our conference will take place March 11th through 13th, and it is graciously hosted by our friends from Tulane University School of Medicine at New Orleans, Louisiana. The conference will be constructed in a hybrid format, and there are different options with regards to in-person and virtual attendance.
Eliana, that was beautiful. Thank you so much. And I don't think anyone here knows how much you helped throughout the day for organizing the summit today. So thank you. And I also want to thank the other people that worked very hard on organizing this today. Many of them are still on the call. And so I just want to thank all of them too. I don't feel like I had to do too much, to be honest. They did all the work and they did a great job. Today has been excellent. So I want to thank everyone for attending on a Saturday. I know many of you have other things to do on Saturday, so I really appreciate everyone attending. Is there any other announcements? Otherwise, I'd say we're probably good. There we go. Oh, I like it. There's all the people that helped coordinate the team. Beautiful. Thank you to everyone. And again, congratulations, Eliana. Thank you for closing it out.
Thank you, everyone. It's an honor to be here.
Thank you.
An honor to work with this awesome team.
You were awesome, all of you. Thank you so much.